Afternoon, everybody, and thank you so much for being a part of this session and for organizing this session. Thank you so much, Dr. Tariq. Thank you.
Thank you, madam. Thank you for giving us the time. And
we have a video also, but I think you can start the session. I'll play it sometime in between. The inaugural video, the IOC.
Thank you, Dr. Namrata.
Thank you, sir. Thank you, sir, for being there. Thank you so much.
So, should I start?
Yes.
Good afternoon, everybody. Here, Professor Namrata is here. And I know Professor Sharfuddin and Dr. Partha Vishwas, who are the chairpersons of today's program. They will be joining us very soon. With their kind permission, I am starting the program. Today, we have Ophthalmological Society of Bangladesh Symposium. Our theme is Ophthalmic Advances in Bangladesh Beyond the Capital City. We have 6 presenters from 6 corners of Bangladesh. They'll be presenting how ophthalmology has been advanced in their parts of Bangladesh. And along with us, we are so much blessed that we have Professor Bianar Subodhi, Dr. Chaitra Jayadev, and Professor Dr. Jyotirmoy Vishwas with us. They are also here, and we are really, really very much blessed. So without any delay, may I start with our first presenter, Dr. Khairul Islam. He is, that is Solo. He made a hospital in northern part of Bangladesh, and he will be telling us about reaching the hard to reach people with eye care service by Deep Eye Care Foundation in northern Bangladesh. Dr. Khairul Islam, please.
Thank you. So I'm going to share my video. Sorry, my presentation. Yeah. Just
can you make it
can you see?
Yeah. Can you make it full screen?
Can you make it full screen, please, Dr. Khairul?
Yeah, full screen. Can you see the full screen?
No,
it is not still full screen. Okay, we start.
Our glass.
Okay. So I'm Dr. Khairul. I'm the Executive Director of the Eye Care Foundation. At the same time, I'm an ophthalmologist. So I'm going to tell about how we are reaching the hard to reach people with eye care services with our organizations in northern part of Bangladesh. So this is the district division, Rangpur division, very much close to Indian border, Shiliguri, and it is around 400 kilometers away from Dhaka. So here we're working.
Your slides are not running, sir.
Slides are not moving. So you have to make full screen, then only it will move.
Yes. It is not still there.
Okay, sorry, just a minute. First man is going to have some problem, but it was working, Okay.
Second slide has come.
Yeah.
You carry on, Dr. Khairul, please.
Yeah. Okay. So you see, this is the Rangpur division, and here we have got 8 districts, and it's 16 million people lives there. So we have started our services covering all the districts, and by our primary eye care center, and at the center we have got a tertiary level eye hospital at the city of Rangpur, and we have started planning to develop a secondary level eye hospital so that we can cover this total areas. And this is the hospital. This is the left side. You see, it's our hospital building, and this is our academic building, that is Deep Institute of Community Ophthalmology. So
slides are moving.
Your slides are not moving, Dr. Khairul.
You have to make the slideshow. Go to the slideshow.
Go to the slideshow, please.
On the top left-hand corner. Slideshow. Yeah, correct. Just slideshow.
Okay.
Click there.
Yeah. Now.
No, it's not good.
I want to. Slideshow just yeah. Slideshow. Can you see, sir? No.
No, still it is not there.
Oh.
So, then you can go to the next slide, please.
Okay. Okay. So this is the health checking scenario of our country, and maximum portion of the people do not have the right health facilities, and we are telling them the hard to reach people, especially the northern part. Yeah. So what are the causes of what are the barriers to our eye care services? We have seen that our 5 A's are most important: the lack of affordability, lack of accessibility, lack of attendant, and lack of awareness, and lack of accessibility. So we have tried to address these barriers in 2 ways. There is vertical approach and the horizontal approach. In vertical approach, through our hospital, we have got through our base hospital, we are providing OPD, IPD, and surgical services. We have got sub-specialists. Almost all the sub-specialities are present here, and all the diagnostic facilities are here. And we give importance on developing human resources and training as well. And conducting research work is one of the important issues of our organizations. So this is the vertical approach we are doing here. And through the horizontal approach, we conduct eye camps so that we can reach to the grassroots level. Through the vision centers, we can address the problems of the people who are really hard to reach. And to develop developing the BCC, build channels communication activities. We're developing awareness and community mobilization, one of the important issues of our activities. And through for the school children, we have got different programs, like we have got district corner and school site testing program as well. So these are the sub-specialties we have got in our organizations, and almost every sub-specialty we are trying to cover, but still we have got some shortage, and in future definitely it will be developed. So to make our services affordable, so we keep our prices. For the OPD charges, like less than $1, which is almost 100 taka. And within that amount, we provide even sub-specialty service as well. So we don't have any piecemeal service charges, and the poor portion of the people, or those who can pay, they are done their surgeries even at the free of cost with donor support, or even with our in-house support as well. And to make it accessible to everyone, we provide here the comprehensive eye care services, and we conduct regular outreach camps. Every month we conduct around 20 camps, and through vision centers we we provide the primary services to them, and community volunteers, and they help a lot to bring them into our services. And meanwhile, we have developed a app, that is Dishtubundo app, which was very much effective during the COVID situation, and we are providing the services to our remote areas people with this app. Yeah. And at the attendants are one of the major problem of uptaking services. So field organizers and community volunteers, ophthalmic assistant, our other stuff like friend of sight, they plays an important role to get the to fill up the gap, And we also provide while caring the patients, we drop even after doing surgeries, we drop them at their community areas again. So for raising awareness, as I said, we have got a lot of materials like IOC materials and others. We conduct seminar, community meetings, and at social level, we conduct different idea exchange. These sorts of meetings we conduct with the community. So, and for acceptance, we try to make our hospital patient-centered, and clean and green environment is one of the main component of our organizations. We try to keep our service in quality. Patient satisfaction is one of the major factor, and so that we conduct survey on patient satisfaction, and we keep on very much a sharp look on it. And we don't have any hidden charges.
Dr. Khairul, actually, I'm sorry to disturb you. Our time is very short, so you have to conclude within 1 minute, please.
Okay, sure. So this is within 14 years' time, on 17 million people have been served, and 500,000 people are vision corrected. And you say around this number of more than 100,000 surgeries have been done. And if we are conducting here ROP for retinopathy, we are conducting DRE screening, and at the same time we have been incorporating artificial intelligence in our hospital. So that this is the first time probably in Bangladesh we are doing it, and this is the thing we are doing cornea transplantation as well. And for the training we are doing it's one of the important thing, and with the collaboration of these organizations, and we are searching for more other collaborations as if we can expand our services for the for the people who needs services. So to targeting the SDGs, we need to give a good vision to unlock the human potential. Thank you.
Thank you, Dr. Khairul. Thank you so much for your brilliant presentation, but we couldn't see as because the slides were not moving. But you see, now I can tell you that our chairpersons, Professor Sharfuddin Ahmed and Dr. Partha Vishwas is here along with us. Would you please stop your slide sharing, Dr. Khairul?
Yeah.
And our co-chairperson, Professor Ashraf Said, is also there. Dr. Partha sir, good afternoon, sir, and welcome you to our session. May we go to our second presenter, Dr. Murtuza Nuruddin. Murtuza Nuruddin is from Chittagong, and you know Chittagong is the southern part of Bangladesh, and it is very famous for Surya Sen, who is that is and the British India. He is our martyr and he was a freedom fighter. Yes, sir.
So before Dr. Murtuza starts his talk, one small comment that I would like to make for the first speaker, and it was a very nice synopsis of what you have really done. And in India as well as in Bangladesh, we have the same problems in scales which are different in different regions, but the problems are absolutely the same. And we had done a study in the Western India. It was a very large study in which we wanted to prioritize what is the assessment of health care and eye care by an individual who is living in the poverty zone. And what we saw is it is in a priority list of 10, it comes to the point number 9. So 1, 2, 3, 4, 5, 6, 7, 8 are other priorities which start from the daily wage, the daily food, then next the shelter. All these are more important as priorities to our population which are underserved. And they do not, even if they have an extra amount of money to get an eye operation done, they will not travel even 1 kilometer to get it done because that little extra money has to be utilized for something else. So the priority is very, very low for eye care in our underserved population. I think this also, I mean, in Bangladesh, you would also have had studies on similar stature. Yeah. And possibly you would be finding the same thing. So I think it's very deep-rooted a problem, and the government has to take up it very seriously if we have to mitigate the eye problem of our countries. Thank you.
Everywhere, even in Bangladesh, there is the darkness around the light. You see, only they 20 kilos away from Dhaka, there is the area Manikganj. In a single day, there was a camp and we got about 1,000 patients in a day. How it can be? So the people they are not interested to come back. Okay, we will talk later on and we can go for Murtuza Nuruddin. Okay.
Thank you, sir.
Thank you, sir.
Yes, our respected chairman, co-chair, and moderator of this session, and dear audience, good afternoon, everyone. I am, as told already, I am from the southeast part of Bangladesh, from Chittagong. I am Dr. Murtuza Nuruddin. I am the oculoplastic surgeon working in this field for more than 16 years, and during this period, I have come across so many surprises and achievements in oculoplasty, which I want to share with the audience through some of my cases. As we know, orbit is a Pandora's box, and so there are so many surprises because various pathological process that involves various structure in the orbit and adnexal region, which may lead to a variety of lesions. So let's start with the cases. This is my first case. It's a 6-year-old girl presented with huge proptosis in her right eye. And on CT scan, we found a huge cystic lesion involving the entire orbit. We excised the lesion, drained the fluid, and then we did histopathology. It came out as pielocystic astrocytoma without any brain tissue. It was a big surprise as diagnosis. So we reported this as a case report in a reputed journal. Then another case is a 7-year-old girl with expanding mass in the supraremedial to right globe. And it was palpable non-tender swelling with mild proptosis. There was also extracorneous homogeneous soft tissue. In computed tomography, we did excision and histopathology showed brain type tissue and meningeal type tissue. And there was also glial cells in the brain tissue, and it was actually ectopic brain tissue in the orbit, which was also a big surprise for us. Let's share some achievements. Both these cases presented with huge Duffy swelling in infraorbital region. Clinically, we diagnosed these cases as lacrimal sac rhinosporidiosis. We used to do DCT, but because of many problems, we planned to go for modified DCR with intubation. And we did modifications like all the sac content along with medial sac wall and lateral sac wall, except a small portion around canal colon opening was excised. And then extensive cauterization was done. Povidone iodine gauge was soaked and kept for 2 minutes, and a large nasal flap was prepared, and after intubation, it was sutured with remaining lateral stump of lacrimal sac. We have done a good number of cases of lacrimal sac rhinosporidiosis in these cases, and so we reported all these cases as original article in a reputed journal Orbit in 2014. Then this is a case of 35-year-old lady presented with gradual mass with non-axial proptosis in supranasal orbit for 3 to 4 years. Clinically and radiologically, we diagnosed this case as orbital lymphangioma. We treated this lesion as with bleomycin injection, and after 2 injections, the lesion was completely resolved. This is also, there are a number of cases were treated like this and were reported in a reputed journal. This is a case of 9-month-old boy with right-sided facial swelling, and radiologically, it was diagnosed as interosseous hemangioma in zygomatic bone. We treated this case orally with oral propranolol, and to our utter surprise, within 5 months, the lesion was completely resolved. This old lady, 68 years old, with multiple systemic problem, kidney and problem and ISD. She presented with growth in her left eye, and the general anesthetist was reluctant to give anesthesia. So we could not go for exenteration. Instead, we go for extended enucleation with amniotic membrane graft. Of course, the diagnosis was a carcinoma with squamous and mucinous differentiation, but the excision was complete. So the lady was doing well even post-operatively, and with proptosis, she was looking good. This is a case with huge lesion extending from upper nasal to upper temporal limbus, around 18 to 10 millimeter. He had undergone surgery thrice, followed by topical mitomycin C. This was actually a case of recurrent ocular surface neoplasia. So we had treatment options of extended enucleation, chemotherapy, or immunotherapeutic agent like interferon alpha 2b, but interferon alpha 2b is not available in our local market. Instead, PEG interferon alpha 2a is available. So we plan to give intralesional and topical PEG interferon alpha 2a, and we treated with this injection and also prepared topical drop for the patient. And on first follow-up, there was improvement. On second follow-up, there was also more improvement. Instead, we give some more intralesional injection. The drop was continued. After 12 weeks, the lesion was completely gone. And after 6 months of complete resolution, there was no sign of lesion and there was no recurrences also. This was also published as a case report in a journal. These two cases, they presented with sebaceous gland carcinoma with orbital extension. So usually go for exenteration in such cases, but both the patient had good visual acuity 6/9 and they were not ready for exenteration. So we were in dilemma whether to go for excision or exenteration. Finally, we did wide excision with reconstruction and reconstruction with mucous membrane graft, and luckily, there was no recurrence in 6 months. Patients are still doing well and under our observation. This is a case of extensive dog bite injury. The boy was presented in our emergency department. There was a avulsion of the complete avulsion of the skin and lacrimal system. We repaired the lacrimal system and we did the reconstruction by rotational graft. And finally, this is the facial appearance that we could just the best that we could give to the boy. So pathological process in orbit and its agnosial area are full of surprises, and achievements through thoughtful management are also manifold. Thank you very much for your patience hearing. This is our beautiful Chittagong. Most of you must have visited here. Those who are not visited, I invite you to come here and enjoy the beauty. Thank you very much for your patience hearing.
Excellent presentation. Now, our chairperson, Professor Sharfuddin, Dr. Partha Vishwas, and Professor Ashraf Said, co-chairperson, do you want to comment on his presentation, sir?
Only one thing I can say, that Murtuza has presented the Pandora's box, and he has presented such cases which are not likely to see in some of the patients, because some patient becomes away from our hospitals. And I think he has mentioned about the interferon, then he has also bleomycin, he has also given some of the treatment and excision, and there is no recurrence in some of the sebaceous gland carcinoma. I think all the presentation was very good. Thank you very much, Murtuza.
From my side, only one comment. The last slide is the best slide. So I definitely wish to come to Chittagong.
Dog bite, yes.
And you have to come, sir. You
must have to come, sir. Be our guest, sir.
Yeah.
Thank you.
So we are moving to our next presentation. Our third presenter is Dr. Abu Naim Muhammad Yusuf, and he is from Sylhet. Sylhet is the eastern part of Bangladesh. Dr. Yusuf is here.
Yes.
Start your presentation, please. Share your slides.
Good afternoon.
How much time we will get, sir? Only 1 hour, or we can extend our presentation, sir?
No, it's only 1 hour.
Okay. So you just start the time.
Yes.
Yeah.
Yes. So next presenter, Dr. Yusuf, please.
Is my slides are shown?
No, not yet. Share screen, please. So
another person should be ready.
Yes, Dr. Mohammad Shafiqul Islam, are you ready for your presentation? Dr. Yusuf,
I can ready. I'm ready, sir.
Okay. Then Shafiq will start, and later on Yusuf will come. Share your screen.
Full screen, please. Huh?
Okay, full screen.
Nice.
Thank you, Dr. Tariq Rezali, sir. Honorable Chairperson of today's virtual scientific seminar, Professor Dr. Sharfuddin, sir, and Professor Partha Vishwas, sir, other faculties from Bangladesh and India, and all other participants, very good afternoon. I'll talk on screening of diabetic retinopathy in southern part of Bangladesh, that is Borishal division, and what is our observations. There is one of the major cause of blindness worldwide, and early diagnosis and management is very important to prevent the blindness from there. This is the location of Borishal division. Is located in the southern part, away from the Dhaka, and is side of Bay of Bengal. There's a lot of river in Borishal divisions. And previously, we have no center for deer service, unfortunately. Considering this fact, a NGO, Australian NGO, Federalist Foundation came forward. And with the help of them, we established a deer project and screened the patients. They extend our existing health system and link with the non-government hospital, non-government association, that is Diabetic Association of Bangladesh. All of you know, Diabetic Association, most of the diabetic people of Bangladesh are registered there. So we target Diabetic Association. So is the bottom is the Union Health Upazila Health Complex, that is sub-district level. There is no ophthalmologist, but we train the nurses. They can capture the picture with the portable fundus camera. Then they refer the, if need, they refer the patient to the Sadar Hospital. District level. In district level, there is the ophthalmologist as well as the high resolution camera. And also, they can also refer to the divisional hospital, that is Sher-e-Bangla Medical College Hospital, where I are working. But we have very strong horizontal referral system from the non-government hospital, that is Diabetic Association of Bangladesh Hospital. So most of, as this is the patient bank, so we target them. This is the project area. Out of 6 districts, our project is the 3 districts only. In every district, on government hospital and on the Diabetic Association Hospital also included. So basically what Federalist Foundation done for us, manpower development or research development, logistic and instrumental supports, development of deer centers, especially IT support, record keeping, they record manually as well as in the computer. But when they focus mainly on also in the big role in the social awareness, Gombira social program, folk song, many way they raises this thing. So initially, with the help of the deer, we done a study, a survey in the Borishal division, all 6 districts, 32 sites, diabetes prevalence was 18%. So if we go through the variables, we retrospectively review all the records. We scanned 3,299 patients with these 3 years. And all the variables we documented and recorded, especially socio-demographical, clinical, as well as biochemical, all the variables we recorded. Prevalence of deer in the southern part in my hospital is 32%. And if we see this, the severe NPDR and vision-threatening PDR at leader plus is 7 plus 3, most total 10%. If we go some of the other variables, there is no difference between main age group between 2 deer and non-deer group. BMI is slightly lower in deer group, and duration of DM is significantly higher in the deer group, and the blood sugar is also significantly higher in deer group, and the vision is poor in the deer group. Though there is no mean difference, but when we do the age grouping, we find more patients from the 4th, 5th, and decade, and maximum from the 5th decade. Male patients suffer more in our study, our findings. People from the low illiterate and low education people also suffer more. Patients, those who were registered to the DAB center, as they visited regularly, so they found less deer. But those who are not registered, they are more prone to develop the deer. Patients who are severely diabetic, receiving on insulin, they are more deer. Unemployed or jobless people suffer more from the diabetic retinopathy. These are the regression models showing the age, male sex, duration of DM, and blood sugar, BMI, or insulin. These are all the risk factors. This is the other comparison with the other studies regarding the BMI. So some of the limitation of our project or our studies, it is a hospital-based study. It may not reflect the original scenario in the community, but sample size is good, more than 3,000. But some of the data is incomplete, so we cannot comment about the serum creatinine level or lipid profile or HbA1c. So last of all, we can tell deer is highly prevalent in Bangladesh as well in the southern part of Bangladesh. So we have to regular checkup, good blood sugar control, health education, social awareness, all are the very important for the prevention of the blindness from the deer. This is my hospital, one of the biggest hospital of Bangladesh. 50 years we have anniversary, and our Professor Sharfuddin sir also from this medical college hospital. These are some of the activities. These are the visitors from the Fellows Foundation from the Australia, Google peoples, also from the Nepal and Kenyan people also visited our center. They are happy our performance seeing. And this is the royal guest from the royal family of the UK and the British High Commissioner. This is our ADD sir and sir. This is the remark from our British High Commissioner. Thank you very much for giving me the opportunity to deliver my speech.
Thank you, Dr. Shafiqul Islam, for your nice presentation. Any comment from our panelists, that is our chairperson, co-chairperson?
Quick comment again. So I think this study is definitely an eye-opener. And I think there is definite amount of increment in the breadth of the study and also in the length of the study that can be thought of. So Professor JB, Dr. Jyotirmay Biswas is also here, and he'll bear with me that Shankar Nethralaya, LVPI and Aravind Eye hospitals have done huge studies, and they are important also in the subcontinent. So in Bangladesh, I think some of these studies would be emulated, and a proper real-time statistics can be found in all your different districts, and that might be a little different from each other. We from AIOS, when I was chairman Academic and Research Committee, we did a very large study also throughout India, in which we wanted to find out where is the missing link of the diabetic population. So the missing link where we found the diabetic population goes to the physician, but they do not come to the ophthalmologist in time. And the physicians are tardy to refer these patients for ophthalmic checkup. And that is where that was a big missing link, and we tried to address it also. It went into a few publications as well. The other thing that I would really want to suggest is the urban and the rural. There's a divide between the urban and the rural, and you would definitely find, because yours was a hospital-based assessment, the semi-urban and the rural definitely have a larger amount of diabetic retinopathy as compared to the age of the diabetes of the individual. And women in our study were in a greater number than men. And these were a few revelations that we got. I think, a broad-based study at Bangladesh would go a long way.
Excellent. Thank you. Any comment from Professor?
Can I have one comment, please?
Okay, I have just one comment.
Sir.
Professor Shah, I'm just telling, Partha Biswas has already mentioned that there should be a broad-based research work. In our country, I have in one study that there are 2 crore people, about 16, among 16 are pre-diabetic and 2 crore are diabetic. And you see in southern part, there are 18%. But in the urban area, it is 12%. So you have rightly mentioned that in rural area, there is much more diabetic patients. So we should screen them out, and then sometimes ophthalmologists send the patient to the physician for diabetes treatment because we diagnose earlier. So it should not be. It should be from physician to ophthalmologist. In this way, we can just cure the patient's diabetic retinopathy. Thank you.
Professor Shubhudi, please.
Dr. Murtaza has also shown that in their study, it is 32%. But in India, ours mostly we've seen last, as Dr. Partha has already told, the missing link program, it came to around 17 to 18%. That means in Bangladesh, it is very high. And that in the urban areas, leave aside the rural areas. You have not taken into account the rural areas. It must be more than that. So I think you need more diabetic retina screening and awareness program in your country. So that's my comment.
Thank you. Thank you.
Yes.
So we are moving
something, sir.
Yeah.
Ashraf side.
Sir, at the beginning of the diagnosis, the diabetic patients are very much conscious about the disease. But it was seen, but it is seen that they become reluctant when their diabetes is getting old. And that time is the main time for development of diabetic retinopathy. So I think along with treatment, awareness is very much important to prevent diabetic retinopathy and to get treatment for diabetic retinopathy. Thank you, sir.
Thanks, Shafiq, for
Yes, sir.
giving this nice talk from my mother medical college. Thank you very much.
Thanks.
So we'll be moving to our next presenter, Dr. Mohammad Naimul Haq. Dr. Naim, please. He is from Rajshahi. It is also very close to India. There is Indian border. Rajshahi, Dr. Naimul Haq, please.
Share your screen.
A minute or so.
Okay.
This is Yusuf.
Am I seen now?
Or you want to tell us right now, Dr. Yusuf?
If you permit.
Okay, okay.
You can
Full
continue.
screen is not available. Full screen, please.
Full screen.
Otherwise, the slide will not move.
Yes.
Yes.
Now it is full screen.
Yes, Assalamu alaikum. I, Dr. A.N.M. Yusuf from Sylhet, is presenting the role of intravitreal injections in retinal pathology, my experience in Sylhet, the northeast part of Bangladesh. This is the part of Sylhet you see here in the red color. This is the beautiful sceneries of Sylhet. Sylhet is known as the tea capital of tea in Bangladesh. They are the beautiful sceneries of Sylhet. It is also the land of saints. And you can also see the clouds over the top of the trees, and they climb from the tree down to the river and the crystal clear water here. So my topic, the intravitreal injections. These are the therapeutic agents inside the vitreous cavity through pars plana and aseptic precautions. History of intravitreal injections. In 1980 to 2000, antibiotic for endophthalmitis was used and also CNV retinitis. 2002 2004, steroid triamcinolone was used, and 2005 to 2006, the anti-VEGF era begins. There are different routes for drug delivery system. Intravitreal use of drugs are chosen because of their easy availability in the area of action and quick onset of action there. Presently, drugs used intravitreally are anti-VEGF, pigatinib, bevacizumab, ranibizumab, aflibercept, anti-infective, antibacterial, antiviral, steroid dexamethasone, triamcinolone, gases, AR, sulfur hexafluoride, perfluoroethane, perfluoropropane, etc. Surgical anatomy. The site of injection is pars plana. Here you see the ciliary body. Here is the pars plana, which is the posterior part of the ciliary body. And there is a linear relationship exists between the axial length of the eye and the pars plana. So during the development, during giving injection, we have to take in care about the age of the patient. If the age is 1 to 6 months, then the injection site will be 1.5 millimeter away from the limbus. In case of 6 months to 1 year, it will be 2 millimeter, and 1 year to 2 years, it will be 2.5 millimeter away from the limbus, and 2 years to 6 years, it is 3 millimeter. And in case of 7 and onward, the injection site will be 4 millimeter in phakic eyes, and 3.5 millimeter in pseudophakic eyes, and 3 millimeter in aphakic eyes. What should we assess before giving injection? We should have a full history, and systemic examinations should be done for any systemic diseases. Adnexal anterior chamber infection should be treated first. Informed written consent should be taken. Any routine topical medication should be continued. Glaucoma should be adequately controlled. What to give? Switch regulations in Italy says OT with air filtration mandatory, but in Royal College guideline shows dedicated operation theater, but OT is not mandatory. Before giving injections, surgeons should wash their hands and disinfectants. Surgical gloves should be donned, face masks should be on. Preparation of the drug. As I have given bevacizumab in different eyes, so it should be taken from the vial, and in every case they are within the syringe, and needle should be removed before injection, and any resistance should be checked before giving. Preparation is in aseptic condition. Preparation of the ocular surface. Pupillary dilatation is recommended. Surface anesthesia given. Ocular surface is painted with povidone iodine 5% and eyelid with 10%. Sterile speculum should be owned. Paracentesis before injection is not recommended if the volume is less than 2.2 ml.
Okay, Yusuf, you show your experience, please. And we have only 1 minute for you. Your experience, please. Go to the next slides.
We administer by 30 gauge needle. If not available, 27 gauge needle can be injected. Injection at pars plana, inflate temporally, and needle bevel up and towards the center. Sterile cotton tipped applicator is over the injection site to resist backflow. Give the topical antibiotics post injection.
Dr. Yusuf, excuse me, Dr. Yusuf, you go to your experience part, because we don't have much time. We can give you only 1 minute more.
Here, in changes of visual acuity in diabetic retinopathy of different stages, only 5 persons, 7 eyes. There shows the improvement of visual acuity in 6%, that is 85.7%, and deterioration occurs in 1 person, that is 14.3%. And most of the diabetic retinopathy patients are advanced diabetic eye disease, so they are referred to retinal specialist to higher center. And changes in visual acuity in age-related macular degeneration of 3 persons of 6 eyes, all of them have improved their visual acuity. Changes in visual acuity in macular edema of different cases, 7%, 8 eyes, all have improved their visual acuity. So there are low complications with appropriate technique. Endophthalmitis is the graded one. And there are special situations. If there is recent CVD, it should be waited for 12 weeks recommended. Periocular infection should be treated before giving injection, and glaucoma is not a contraindication as well. If there is pregnancy, we have to avoid better in first trimester. Second and third trimester, risk benefit ratio should be assessed, and lactating mother intravitreal avastin or other anti-VEGF can be given. Bilateral injections can be given if there need.
Okay, Dr. Yusuf, we have to finish right now because we have 4 more presenters, 5 more presenters. We don't have much time. Can I ask you to please close your? Yes, thank you, Dr. Yusuf. May we go to Dr. Naim? Please finish your presentation within 5 minutes, Dr. Naim.
Sure. So, Tariq Bhai, I think Dr. Yusuf's presentation was a very important one, which definitely showed that there is a need for our comprehensive ophthalmologists to understand and to take part in the treatment, in the management of the retinal disorders with diabetes. So medical retina, which is actually in the curriculum as of now in our postgraduates, with our postgraduates, needs to be also taught to our comprehensive ophthalmologists who are practicing in the rural areas and the district levels. So thereby some amount of initiative needs to be done at the hospitals, so that this can be disseminated.
Sure.
I'm
And
sorry, sir,
irrational use of this intravitreal injection should not be done. Thank you.
Yes, sir. I'm very sorry that I have to stop him because we have so many presenters and we have to conclude the session within time. I'm extremely sorry for that. May I ask Dr. Naim for your presentation, please?
Sir. Sir, দেখা যাচ্ছে স্যার?
Yes, yes.
Continue.
Full screen, please. Full screen.
Sir, Honorable Chairperson of this session, Professor Sharfuddin Ahmed sir, Dr. Partha Biswas sir, Co-Chairman Dr. Syed Ashraf sir and Professor A.K.M. Muqtadi sir, and my mentor, Dr. Tariq Reza Ali. Assalamu alaikum. And I am Dr. Mohammed Naimul Haq, Assistant Professor, Rajshahi Medical College. I want to share my experience from northern part of Bangladesh, from Rajshahi, between cases, what I have done in my center, in our center. Diabetic eye disease ranks 5th in the global cases of partial or complete loss of vision. 90% patients are from developing countries. Retinal disorders are common causes of visual loss after cataract. There are a lot of retinal diseases which require intervention. Duration of June to 2022 to November 2022, total number 133. The case distribution of my cases, and then this is the graphical presentation of my cases. Male-female ratio, male 76, female 57, and the procedure done in our center. Commonest vitreoretinal disease are diabetic retinopathy, and commonest surgical procedure pars-plana vitrectomy. I want to show some video what I have done in our center. Is the diabetic eye disease. Vitrectomy is going on. Fibrovascular tissue was removed by forceps and high cutting vitreous cutter.
Go to the next slide.
Then another case of diabetic vitrectomy with dense vitreous hemorrhage. Fibrovascular tissue is removed by forceps and high cutting vitreous cutter. High speed vitreous cutter.
Okay, next case.
Sir.
Next case.
There is a full thickness macular hole. The video of full thickness macular hole. Triamcinolone acid is given to dye the vitreous. Limb peeling is done with the help of forceps and finish loop.
short.
Sir,
Yeah.
Performing high-tech vitreoretinal surgery is challenging, and early diagnosis and management can prevent vision-threatening complications. A strong partnership between all subspecialties can reduce the burden of blindness. Thank you, sir. Thank you for patience sharing.
Very good.
Okay,
Thank you, Naimul.
So we have only 10 minutes, 10 to 12 minutes left. And we know that Dr. Devi is here, and we should go to him. What I feel, I need the comments from our chairpersons that Professor JB is here. Dr. Kripadhan Chakraborty is still waiting for his presentation. What should I do? Should I go to Dr. JB or Dr. Kripa can tell something? And then Dr. Chaitra is there.
I think we should finish all the presentations.
Should we go to Dr. Kripa?
Okay, anyone, you can call them.
So Dr. Kripa, just to show your main purse.
Thank you, Mentor Sir, Dr. Tariq Ali Raja Sir, and our today chairperson, Professor Dr. Sharfuddin Ahmed Sir, Honorable Vice Chairman, and other speakers and audience. My presentation. Would you visible slide, sir?
No.
Not yet.
Slide is not visible.
Not yet.
Now visible,
sir? Visible, yes. Go to the full screen and go to
full
the
screen.
Main part of your presentation, please.
By 2 minutes. Kripa, by 2 minutes.
Yes, sir. And my today main topics, retinopathy of prematurity.
Okay.
Title of frequency and risk factor for retinopathy of prematurity neonate in NICU, Mymensingh Medical College Hospital. Now I am working professor in charge and head of the department, Kumudin Women's Medical College, and related to Dr. Kajaman BNSB Eye Hospital, and as a senior consultant. And my area in northern east part of Bangladesh, and here population more than 17 million population related here, and working area more than 6 districts. And this is my presentation, retinopathy of prematurity in outside Dhaka, in started 2018, and with the collaboration of BSMU, and it is alarming issue in more than 40,000 blind in ROP. That's why it is in magnitude of ROP in Southeast Asia, on 7th position. In Indian expert ROP survey team reporting in our area, Mymensingh region, NICU, Mymensingh Medical College, and CBMC ROP screening program started. They are alarming 1 to 2 babies out of every 20 screen require treatment, and 20 babies would surviving with blindness every month. That's why in our area needed ROP service. And in this study, objective to find out frequency and risk factor of ROP, and specific and associated risk factor, and study duration July 2022, and Mymensingh Medical College and our institution, Dr. Kajaman BNSB Hospital, total sample size 178, and birth weight less than 2 kg, and gestational age 35 weeks, and associated neonatologist advice patient are screening. Exclusion criteria also congenital cataract glaucoma and congenital anomaly, and equipment are available, especially in outside Dhaka, in indirect ophthalmoscope, RADCAM, and it is a database software ROP screening in help of Orbis International, and ROP evaluation for accordingly. ROP screening neonatal intensive care and Mymensingh Medical College started 2018, and here our one of the moderator, Professor Nozha Chaudhary, started this program in NICU, and in study collaboration in 2 hospitals, Mymensingh Kejaman Hospital and Dr. and Mymensingh Medical College unit. Here, neonates were evaluated 1721. 3 neonates died and 4 neonates lost of first follow-up, and ROP found 27.5%, and treatment required 18 patients here, and now already follow-up done, and gestational age and less gestational age, more in ROP, less birth weight, more in ROP, and male-female ratio, male more, and among the frequency stages of ROP, and especially 3 and 4 stage, and APROP, now it is called AROP. It is more significantly, especially low birth weight and less gestational age. And less gestational age.
Okay, fine.
And duration of oxygen also important, and other factors, multiple gestation, oxygen therapy, sepsis, RDS, CP, FP, also ventilation support also, and blood transfusion, perinatal asphyxia also, antenatal steroid, and it is related to, and our facilities in medical retina, mainly periphery, and LIO laser and intravitreal injection facilities available. Overall frequency of ROP 27.5% in our this study. And conclusion, with the increasing survival of premature infant and increasing incidence of ROP, that's why finally some limitation, a single center and short-term evaluation are outside study, my institutional limitation, inadequate manpower, lack of awareness, new concept, mind setup also. Key message, increase in level of NICU care, there is rise of incidence of ROP, however, no corresponding increase in awareness. That's why our needed screening program, shortage of equipment and skilled ophthalmologists. ROP service requires in a team approach.
Okay.
Thank you, Dr. Kripa.
Thank you, Kripa. Thank you very much.
Here, few picture in ROP awareness program here, and hands-on training in outside faculty in your institution, and ROP seminar symposium, and finally national symposium in honorable Vice Chancellor Sir, Professor Sir Sharfuddin Sir present here. Thank you, sir. Thank you.
Okay, thank you.
So we are running short of time. Actually, there is no time, Professor. So what should I do?
You can invite another one. No need of any comment.
Dr. JB sir is here, sir.
So you want me to present?
Yes, Dr. Subudhi and Dr.
Yeah, can I present, please?
Dr. Subudhi sir?
Yeah, can I present?
Yes.
Can you stop the screening?
Yes, Kripa, stop your screen share.
Yes, sir. Yes, sir.
Tariq.
Yes, sir.
Can I present? Okay, Dr. Subudhi presenting, then is okay.
Yeah, okay.
Dr. Subudhi,
yeah, I'm sharing.
Everybody, please go to mute or not presenting. Yes, sir.
Subudhi sir,
Yes,
for the interest of time, I mean, your take-home messages are always very, very pertinent.
Am I visible?
All of us would like to take that home. So teleophthalmology is very important for all of us.
Is my screen visible?
Yeah. Your screen is very visible.
Thank you, Dr. Tariq and Professor Ahmad, giving me the opportunity. So I thank AIOS, IOC for this grand program, and I thank the OSB to give me the opportunity to speak in the Bangladesh forum. And I don't have any financial interest in this community. Indian perspective, I will be speaking on Indian perspective. So why do we need community eye care? As you know, in India, 45 million in India are visually impaired and 12 million are totally blind. And 1/4 of the world's population of blind are in India. Majority of them are needlessly blind because of they are not diagnosed early. And 80% of these people, they live in rural areas. So we
Professor
speak about the universal eye care for all.
So Buddhist,
am I audible?
No, you're audible, but your slide is not moving and it is not in the full screen mode either. Full screen kar lijiye, sir.
Is it a,
no, full screen now? It is not full screen, sir. Make it full screen, sir. Or there might be some issues then. Then I think, yeah, no, it has gone up, sir.
Now it is?
Sir. Yes, sir. Yes, sir. Yeah, full screen. Yes, yes. Carry on, sir.
Okay.
Carry on, sir.
Okay.
Yes, sir.
So we speak about the universal eye care for all, but the patients in India are very many and located at various locations. Equipments and instruments are limited. Doctors are even more limited.
Carry on, sir. You're audible.
Okay. Yeah, shortage of the two issues. Most of the shortage of doctors and also inadequate infrastructure in our country. So, as you know, India is a country of diversity, and the geographical location plays a major role. And also, not on every nook and corner of our country is easily accessible. You can see the photos in the down. And there is one ophthalmologist per 1 lakh population in our country, and 80% they live in the urban areas, and 80% of healthcare is also available in the urban areas only. But 80% of people live in the rural areas. So, thus, there is a lot of advancement technology. Why don't we utilize this technology for the treatment of this 80% of people in rural areas? So, this concept called teleophthalmology come into existence. Teleophthalmology allowed clinicians to provide quality healthcare outside of clinics through digital technology that's improving access to medical care, patient outcomes, and overall patient satisfaction. So this is the teleophthalmology concept, a mobile van with the following equipment. I will show you the equipment. They go to the rural areas, they screen the patient and send the data, images mostly, to the base hospital where they are integrated. So these are the instruments, they are portable instruments which are carried by this mobile van. And usually a local doctor or optometrist, ophthalmic assistant, trained health workers will utilize to take these photographs to transfer the images to the base hospital. The teleophthalmology can be utilized in various ocular conditions. All these conditions can be utilized, including the diabetic retinopathy, ROP, glaucoma, even refractive errors too. So objectives of teleophthalmology is to make eye care service available, accessible, and affordable by reducing travel cost and time for the patients, and to enable people at remote areas to have access to the specialized and modern eye care facilities. It has got a lot of advantages. These are the advantages. I don't want to tell everything, but I can say that we can avoid unnecessary referrals, and we can educate the people in the rural areas too for the health awareness of the program. I mean, about the blindness. So now there are a lot of new additions have come to in the digital technology. They are the artificial intelligence, 5G, and metaverse. These can be added to teleophthalmology to give a better picture. So 5G technology, now it is almost available in our country, and it gives a much faster speed of data transmission and lower latency. And of course, metaverse teleophthalmology, still it is in the infancy stage. These are virtual clinics which can be placed in the rural areas, and the ophthalmologists sitting in the urban areas, they can treat the patients. Teleophthalmology, the future. ATM. ATM is a one-stop digital touch-point integrated machine designed to diagnose the disease, deliver primary care in the early stage of the disease, and this can be installed in public places like the railway station, public the airport, and public markets, where the patient can go to the ATM with a minimum fee, can be examined and given the diagnosis whether it's a referable or non-referable disease he is having. So take-home message, I can say teleophthalmology is the only technology now, it can be present at the doorstep. So it's the only solution for the patients who otherwise not have access to an eye care professional to be screened and treated earlier at the doorstep by paramedics to prevent permanent visual complications. So now we achieve universal eye care for all. So this is the Teleophthalmology Society of India. This is our governing body. And I request all of my colleagues to become member of TOSI. The website is tosi.org.in. Similarly, we plan to have a South Asian Teleophthalmology Society. If my friends from Bangladesh, from Sri Lanka, from Nepal, if they're agreeing, I think we should start this program. The SARC Academy of Ophthalmology countries, we can involve them, integrate them, producing a SATOS, that is South Asian Teleophthalmology Society. So thank you very much for giving the opportunity.
Thank you, sir. Thank you very much. Thank you, sir. So we have two more presenters.
Thank you, sir.
Wonderful talk, sir. Very good. And I think your propagation of teleophthalmology should be taken up very earnestly, sir. Thank you very much, sir.
And we have already talked earlier in South conference that we all will work together in SAC region. Thank you.
So may I request Dr. Chaitra Jayadev, please? Are you here, ma'am? We want to listen from you that pseudophakic cystoid macular edema, the recent advancements. Dr. Chaitra Jayadev. She was here.
Yes.
We cannot hear.
She's here. She's here. Chaitra, we can't hear you.
We can't hear you.
Yeah. No, we still can't hear you, Chaitra. Can you go to slide share maybe first? Or
can I present?
Or I think if JB sir is there and ready, then Chaitra, you can present after JB sir. Is that fine, Chaitra? So JB sir, please start.
Yes, sir. The great teacher, Professor Jyotima Vishwas, is here. Yes, sir.
Sir, can you hear me now?
Yes, Chaitra, we can hear you now. We can hear you now. So JB sir, after JB sir, you can come.
Yeah, no, that's okay. Let JB sir do it, please.
Yeah.
We're already late, sir.
Yes, Namrata.
Partho, just 1 second. Dr. Lalit Verma and Dr. Harbans Lal both are with me here at the AIOS.
Sir, great. Wonderful pleasure, sir. Thank you, sir.
And I'm very glad
Chaitra,
to see.
Can you stop sharing the screen just for 1 second?
JB sir. Yes, JB sir. JB sir, ka screen hai.
Acha, JB sir.
Hi, JB. I'm glad to.
Thank you for giving me the opportunity.
No, JB. I was actually in the other room. We were with the RANSCO program. So
yes, Lalit Verma. Good afternoon.
Hi,
Dr. Sharfuddin.
Hi,
and also, good afternoon to Namrata Sharma. We are working.
Hello, everybody.
Hello.
Yeah. You see, I must thank.
Sir, why don't we invite all of them? Lalit sir, let us invite all of them for AIOS Kochi, sir. It's going to be a grand conference, sir. You do the.
So what I was telling was that, you see, hats off to Namrata Sharma for arranging, you see, 22 countries she has arranged on one single platform. Okay. And I take this opportunity from, behalf of not only President AIOS, but for all the executive of AIOS, all the GC, that very pleased to see all of you here on this meeting. And also I take this opportunity to, welcome you all to our annual conference, which will be a very big affair. And this is in Cochin from 11th to 14th of May. And you must come to this and see the scientific extravaganza which has been prepared by Partha Biswas.
It is our pleasure to join there.
Please.
Thank you.
Waiting for all of you to be there.
Everybody.
You will be going there.
Yes. Inshallah. We will go there.
Thank you.
Okay.
Thank you. Share your...
Thank you. Thank you so much, sir.
Can I share the slide?
Thank you.
Yes, yes, please. Yes. JB sir.
Okay. So I think time is short. I'll be very brief. I'll be talking on uveitis search for the cause. Uveitis is one of the cause of visual morbidity. And the most important aspect of this, that is not moving. Yeah. So what is the cause of the uveitis? Etiological diagnosis remains a challenge all the time. So I often feel like that the patients don't ask me that what is the cause of the uveitis, or the student don't ask me what is the cause of the uveitis. No matter, you may say that no matter what causes it, I'll treat with the steroids. That's not the true. Investigations are required to identify autoimmune infectious uveitis to identify specific uveitic entity, to obtain diagnostic, prognostic information, and take therapeutic directions. So I'll be showing some cases only. This is a 30-year-old male, pain, redness, photophobia for 3 days, and you can see that there is a hypopia and fibrin in the anterior chamber. What test you will do? How do you approach? For me, the history is very important. Is it fast episode? Is there recurrence? How is the previous response to treatment? Is there low backache? Is there oral or genital ulceration? If there is no oral or genital ulceration, I would do that HLA-B27 first. And that would be my first investigation. But in a scenario like this, where a 30-year-old man, not much pain, not much redness, but multiple keratic precipitate. In our country like India, where I should do that TB and sarcoid first, that Mantoux quantiferon TB gold test, X-ray test, if possible, high-resolution CT test, and serum angiotensin converting engine to rule out sarcoid. So TB and sarcoid to be ruled out first. So if it's negative, we should go for any facility is available to do the PCR, polymerase chain reaction for Mycobacterium tuberculosis from AC-TAP. In that particular case, AC-TAP was positive for Mycobacterium tuberculosis DNA. This is a patient, 59-year-old man with a pigmented keratic precipitate. Intraocular pressure was very high. What could be the diagnosis and what test we will do? In this case, the suspicion of raised IOP and with the pigmented KPs will indicate a possible etiology of viral anterior uveitis. As virus cannot be cultured, we will need to do the polymerase chain reaction for AC-TAP, for HSV1, HSV2, VZV, and CMV, both nested and real-time. And in fact, the real-time PCR was shown for HSV1, was positive in this case, and patient responded to antiviral treatment. This is a patient, 20-year-old male, no pain, redness, and protest. There are fine keratic precipitates are present. And in this case, you do not need to investigate because it's a fuchs uveitis. It's a kind of an autoimmune uveitis. You won't find anything by investigation. No need of steroid before cataract surgery, gratifying results with FECO and IOS. This is a 25-year-old female, blurring of vision and floaters. And you should look for the vitreous cells and debris. If you see that such vitreous cells and debris, you will look for immediate ophthalmoscopy very carefully for exudates in the inferior vitreous and retina. So our pars-plana exudates, this is intermediate uveitis. And in such cases in our country, like rule out TB and sarcoid first, you should do the Mantoux quantiferon TB gold test, serum angiotensin converting enzyme to rule out sarcoid, and HSCT test to rule out TB and sarcoid. And in this particular case, it was found to be Mycobacterium tuberculosis infection, parenchymal infiltration of the lung or with the high-resolution CT test. And PCR confirmed the diagnosis of Mycobacterium tuberculosis DNA with 2,204 copies. And this is a case of intermediate uveitis, has simple high-resolution CT test, showed hilar lymphadenopathy, confirming a diagnosis of sarcoid uveitis. Now, some posterior uveitis case. This is a 68-year-old male and who had dimness of vision on left eye, 1 month, vision 6-18 and N18. And you can see the 3 nodules are there in the choroid. What do you think? So here in our country, we should think of tuberculosis sarcoid. As the patient is elderly, you should keep the possibility of metastasis also. And you should do a Mantoux quantiferon TB gold test, high-resolution CT test, serum angiotensin converting enzyme estimation to rule out sarcoid. If all negative, do a PET CT scan to rule out metastasis. And this case, as the investigations revealed that serum AC was elevated, Mantoux was negative, quantiferon TB gold test was negative, ESR was raised, and this indicates possible etiology of sarcoidosis by investigation alone. And this is a patient, based on the investigation, treated with oral prednisolone, and lo and behold, there is a complete resolution of inflammation over the period of time with oral steroid. And 3 months after, the vision improved to 6 and 6, the lesions flattened. This is a similar case, 26-year-old woman, and who had got a lesions in the choroid. This is a single solitary whitish lesion, and this is it TB or sarcoid? This is a dilemma. If we do the pulmonary chest X-ray itself showed pulmonary tuberculosis, and there's a miliary lesions in the lung, and cervical lymph node biopsy showed necrotizing granulomatous inflammation. And this patient responded to the treatment, as you say, with the anti-tubercular therapy from the previous lesions of the, on the right-hand corner was the early lesion and the complete resolution of the lesions. And this is a multifocal choroiditis. Here you should think of the possibility of APM-PPA, that is acute posterior multifocal placoid pigment epitheliopathy, multifocal serpiginoid choroiditis, sarcoid, and lastly syphilis. And these are multifocal pigmented multifocal serpiginoid choroiditis, which is thought to be now tubercular origin. And here you should do the X-ray chest, HRCT chest, or Mantoux test, quantiferon TB gold test, serum angiotensin converting angio, and VDRL and TPHA to rule out syphilis, which can produce placoid lesion. Here is a lesion showing a retinitis, and you can see the fluffy white lesion and whitish patch, ill-defined margin, associated retinal edema, overlying vitreous cells, a leading edge of the lesion, and blood vessels cannot be traced over the lesion. And this is a retinitis, almost always infective except vessels disease. And when you see the such retinochoroiditis with localized vitreous cells, clinically the phenotype tells you that this is a toxoplasma origin, and it should be treated with anti-toxoplasma treatment with oral steroids started 48 hours after. The clinical diagnosis elicited to confirm PCR of intraocular fluid in atypical cases like this, which was an HIV positive patient, diffuse retinitis was seen, and PCR was positive for toxoplasma. This is a case of acute retinal necrosis, and you should do a viral test, PCR for HCHV, HZV, and CMV. HZV was positive. Patient, based on the investigation, treated with antiviral treatment, both oral and intravenous. Ganciclovir given, and timely barrage laser was given to salvage the vision. This is a case of the vitritis with dense exudates, as well as the retinal vasculitis with a 34-year-old male, sudden dimness of vision. So if it doesn't fit with the known clinical diagnosis, one should think of syphilis and the good history of exposure, VDRL or RPR, which is a non-treponemal test, and FT-AVS and TPHA, which should be done. And this was positive for VDRL and TPHA. Patient responded to the treatment. Case of retinal vasculitis, here is the case. We can see the retinal vasculitis with the exudates, and there's a thick exudates over the retinal vessels. And you should do the Mantoux quantiferon TB gold test, HRCT test to rule out tuberculosis. Indeed, it was a tuberculosis. And with the ATT and steroids, you can see there is a complete resolution of the lesions, improvement of the vision. And this is not a TB. Here you can see the skip lesions, candle was dripping. This is due to the sarcoid, and this was confirmed by the HRCT test showing bilateral hilar lymphadenopathy. Serum ACE was elevated. And this is one of the cases mimicking tubercular retinal vasculitis, but if you look carefully, there are cottonwool spots were there, and this is suggestive of any SLE. And in fact, the patient had a malar rash, and a serum ANA showed immunofluorescence of a positive anti-DS DNA. It was showing that speckled hyperfluorescence. And this is a 20-year-old man, history of fever, dengue, rickettsia, typhoid, and chikungunya should be ruled out, and no specific treatment of the underlying disease, and one need to give oral prednisolone. Last but not the least, don't miss it. There's a muscular syndrome, and is a patient with a hypopian 80-year-old girl not responding to the topical and systemic steroid. In such cases, one need to do an invasive test like anterior chamber tap, which showed basophilic cohesive tumor cells suggestive of retinoblastoma. And this is a 7-year-old girl, acute lymphoblastic leukemia, peripheral blood smear is normal, CSF was negative for malignant cells. You can see the infiltrate in the iris, hypopian, and this patient had on AC tap showed lymphoblast suggestive of recurrence of leukemia. And this is a case of leopard skin-like appearance, and with the vitreous biopsy showed atypical lymphoid cells. Cell blocks showed large lymphocytes with pleomorphism and necrosis of the tissue. The last case is a serpiginous choroiditis was diagnosed, but final aspiration biopsy showed large lymphoma cells with necrosis of the tissue. MRI showed CNS lymphoma. So uveitis of the extremes of age, you think of muscular syndrome, And this is a 55-year-old lady which has got vitreous woolly strand of opacity. One should rule out the endophthalmitis in such cases. The vitreous biopsy was done and vitrectomy showed, in fact, the Congo strain was positive for amyloidosis. So it was not only endophthalmitis, but endogenous endophthalmitis, it was a vitreous amyloidosis. I skipped the last case. There's a chorioretinal biopsy was done and which produced a diagnosis. So what is your diagnosis is often a dilemma, and thoughtful investigations can give to the diagnosis take-home message. The good uveitis history, oriented history, as I mentioned to you before, look at the patient as a whole, identify anatomic location and extent of the uveitis, make a short differential diagnosis, choose the investigations wisely, go stepwise approach, and lastly, fall phase biopsy. Thank you for giving me the opportunity.
Thank you. Excellent presentation. Revision of uveitis whole panoramic view, sir. Thank you, sir.
Thank you.
Excellent. So, Dr. Choitra.
Yeah, I'm here. I don't know if I'm audible now, but
Yes.
we've already run very late in the session. I'm okay if the next session has to start. It's okay, sir.
5 minutes for you, yes, sir.
So, sir, thank you. So what I'll do is I'll just run through my slides, though it's a large presentation all about recent advances in pseudophakic CME, but I will not be going into all the details. Let me just cover quickly on only the recent advances. So we all know pseudophakic CME can be quite disappointing, but how big is the problem really? Clinical CME, at least 2% of uncomplicated surgeries, and angiographic CME is seen in 20% of the patients. And what is important is that those patients with diabetes, since we see a large percentage of them in our population, there it is even higher, especially when there is a pre-existing diabetic retinopathy. So this is basically the overview of my talk, but I'm going to go straight away to the treatment itself here. So we have topical, oral, we have injectables, lasers, and surgery. This is a chart of all the different topical medications that's available. But one of the new ones that there is interferon, and how it actually acts is that it's a different sort of a mechanism of action as against the regular NSAIDs that we have. And this is a study that was conducted at our institute, and we use it predominantly in patients who had complications intraoperatively, and mean duration of complete resolution was 5 weeks in these patients. And we've even published this study. We did find it to be an effective medication for resolution of the CME, especially in this subset of patient. So these are our different publications from our institute. All of them did show that topical interferon for recurrent edema was quite effective. Now, going on to oral carbonic anhydrase inhibitors, well, there have been previous studies on this. This is a good study here. This is a review article on the current management options. This was published in 2021. And steroids, of course, is what we as retina surgeons use. The patient compliance is also better, and especially when you use an implant, it lasts for at least 3 months, and it's very good. But the only risk factor here remains the raised IOP. You have, of course, periocular steroids and both intravitreal injections of a X implant or an IVT. Now, anti-VEGF, yes, we do require second injections, and more than 25% of them would require it. But here there is a lesser risk of IOP rise. So we also have subthreshold micropulse laser. This is no damage compared to the conventional laser treatments, and we used subliminal laser photostimulation. We use a 577 nanometer here with 7x7 grids. Here again, the studies have demonstrated complete resolution of the retinal edema with improvement in BCVA. As far as surgical methods go, it's either to lyse the vitreous adhesions or to release the VMT, or sometimes even to remove the retained lens particle to reduce the inflammatory process. So these are the different surgical modalities. Now, we've done a pilot studies on biomarkers. This is what I wanted to show you, how a patient with edema in both eyes, but with injection, only one eye resolves and not the other. This is why we were prompted to do a study on the biomarkers, and we wanted to look at the different mediators in inflammation itself. What we did was to quantify the soluble factors in aqueous humor. We collected the samples. send it to our Grow Lab, which is situated in one of our centers. And we basically take out these solutes and run them through to see what is the predominant biomarker that is there in a particular patient. So this basically helps us to customize treatment for these patients. So if a patient has higher pro-inflammatory biomarkers, we treat them with anti-inflammatories like steroid. So cytokines such as ICAM1, VCAM1, IL-6, 8, MCP1 were increased in patients in the persistent macular edema group. And this sheds basically light on the non-VEGF mediated pathways. So we're also now coming up with something called as a biomarker kit, wherein at the point of care itself, in your OPD itself, using tears or plasma, we can actually find out what is the biomarker in that particular patient. So we've seen this already in patients with diabetic retinopathy, where we've compared the different biomarkers. This is one case that I'd like to show you, a 76-year-old gentleman with a lasered PDR and CME in the right eye. You can see with anti-VEGF, there was incomplete resolution, persistent CME. And we ran the biomarkers. We saw that the inflammatory biomarkers was more than the VEGF, and an IVTA was given, and there is complete resolution of the edema in this patient who did not respond to VEGF. So to conclude, pseudophakic CME is more common than previously appreciated, rather underreported. That's because we have advances in both OCT and Opta technology that allows non-invasive detection, quantification, and monitoring. High-risk population should be screened actually ahead of the development of vision loss. Therefore, we can give them better outcomes with prompt treatment. Prophylactic treatment is there with improved techniques in cataract surgery itself. There is reduced risk of CME. We should take enough care to prevent vitreous loss in these patients. Perioperative NSAIDs, avoidance of the use of topical PGAs, we know have a high risk for CME. There's a significant need for newer topical IOP lowering options so that we don't risk CME in these patients. And of course, customized treatment options with the use of biomarker kits. So when to refer to retina, I'm not going to elaborate on this, but this is a rather important slide. Thank you so much.
Excellent presentation, Dr. Chaitra. There's so many new things we have learned from your presentation. Really, really very marvelous.
I'm sorry I had to rush through it.
But probably we need to listen to this presentation many more times so that we can come to bring this knowledge to our clinic. So we are at the end of our session, and Dr. Partha has to leave because he has another presentation, another session. May I ask our chairman, Professor Sharfuddin Ahmed, to conclude this session, sir?
Okay, thank you, Professor Tariq Reza Ali. If I say in one line that this is the excellent presentation by all the presenters, but I think all the time when I visit the All India Ophthalmic Congress, I always enriched my knowledge. And today, by presentation from each and everyone from Bangladesh and also from India, I have learned a lot, as because I think everyone has learned today by their brainstorming, as because all the topics, diabetes screening, ROP, there is the orbital diseases, in the ICAMs, how we can increase our knowledge, how the diabetic screening will be increased. And also, lastly, we have learned many things and everything from uveitis. And in teleophthalmology, I think this is very much necessary in future, as because we will not be able to go to hard-to-reach area. So teleophthalmology will be the guide to us in future. And in uveitis, I think Jyotirmoy Biswas, she has very nicely presented and we learned a lot. And lastly, I will ask Dr. Chitra Joydev that you have given one idea that whether there is any study that you are using interferon and anti-VEGF, which one is better in case of CME, of pseudophakic CME. In future, this type of study will be better one, and we will go for the better treatment in future. I think with these few words, thanks to all speakers and organizers, especially Tariq Reza Ali and our co-chairperson Ashraf Said. Only I will not say goodbye to Partha Biswas because always he is with us, not in India, not in Bangladesh, everywhere of the world. Where we go, we work together and he will be with us in future in Cochin in 11th to 13th May probably, and we will be there and we will learn a lot from that place. Thank you very much.
Thank you.
Thank you, sir.
Thank you,
sir.
Thank you.
Thank you.
And now we can conclude. Okay, thank you. Artu will not come. Tariq?
Assalamualaikum. Thank you, sir.
Okay,
Thank you so much. Thank you.
Murtuza, Deep, Ashraf Said, Kripa, and Tariq Rejali. Okay, thank you.
Thank you, sir. Assalamualaikum.
Assalam.
Assalamualaikum, sir.
Oh, Shafiq is also there.
This sir.
Thank you.
Yusuf,
Firdaus, Jolly is also there.
Yusuf.
Yes, sir.
Okay. Right.
Leave
মিটিং শেষ না একজনের মনে হয় একটা সমস্যা হয়ে গেছে এখানে তো আছেই সবাই বন্ধ করে দিচ্ছে meeting shares to catch up on 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 meeting shares to catch up
Hi, is that Dr. Ramina?
if someone is there from backend team, can I check my share slides?
Yeah, ma'am, the permission has been given to you.
Okay, can I try right now or it's already live?
Yeah, it's not live on the platform, so you can try.
I can try? Yeah, I'll just share my screen.
Yeah, sure, ma'am.
So I have a video which has audio in it. So can you just tell me if audio is also audible? This video demonstrates. Is that okay?
Yeah, audible. It is audible.
Okay, thank you so much. I'll stop sharing. Thank you.
Good evening, Tanuj.
Hi, Tony. How are you?
Hi. Good.
Nice to see you.
Yeah. Will you be going to the APAO?
No, Tony, APAO, I'm not going.
Oh, okay. We'll miss you. How's everything in Delhi?
Everything very good.
No, good. So no, everything's quiet now, COVID-wise, right?
Yes, absolutely. Hello, Dr.
Good
Sushma.
evening.
Good
Hi,
evening.
Dr.
sir.
Sushma. Good evening.
Hi. Good evening, Dr. Anthony. Yeah, we are all early birds.
Yes,
Oh, yeah.
Good.
So, So this is day 0 of the whole meeting?
Yes, it's Friday,
Okay,
Saturday,
great.
Sunday. Today is started at 3:30. Today's day day 0, yeah.
Oh, excellent, excellent. And this is a yearly meeting, right? I remember participating last year as well.
Yes. This started in the COVID, so this is the 3rd meeting. So
excellent.
Hello, Shamira.
Hi, Shamira.
How you doing?
Nice to see you.
Yeah.
Shamira, do you want to go early in the sequence or late, or 3rd is okay for you?
Fine by me, sis. Yeah, I'm looking forward to it. Yeah, 3rd is fine.
Okay, fine.
How's everything in Singapore, Shamira?
Oh, I've been having a miserable time recently. It's been raining every single day.
What?
I don't know. I had some friends from the UK. They said it was actually less wet in the UK.
That's unusual.
Yeah, I know. How are you guys? You're going to KL?
Yeah. How about you?
Yeah, so I'll be staying for the whole 5 days, I think, 4 days.
Oh, great. When are you arriving?
Wednesday night, I think, late at night.
Okay, great. Hope to catch up with you if you're not busy.
Oh, definitely will do. Yeah. Tanuj, you going?
No, APO I'm missing.
Oh no! Looking forward to seeing you.
No, you can't go everywhere. I went to APGC, then this time I have to skip.
Oh, okay. We'll catch up another time then for sure. WGC, you'll be there, right? In Rome?
Yeah. WGC, I'll 99% I'll be there.
Okay.
We had a lot of visa problem recently. Euro visa is getting very difficult to get.
Oh dear. Okay.
And you don't have. It's a good thing you don't have a problem, Shamira.
No, so far so good. How about you? Are you traveling a lot, Tony?
Not so much yet. Not so much. How about you? Are you, going to a lot of conferences?
Yeah, I mean, basically trying to get back to what the travel levels were before COVID now. Probably like one a month, something like that, going out somewhere.
So Shamira and Tony, I don't think you know. Let me introduce Dr. Sushma Tejwani.
Hi there, Sushma.
Hi again, Sushma.
Glaucoma chief at one of the leading eye hospital, Narayan Nethralaya, Bangalore. And
excellent.
Glaucoma specialty. She's the most awarded glaucomatologist in India. All the awards, all the conferences, glaucoma, she has got.
Dr. Tanuj is being very generous.
No, I'm speaking truth.
Yeah, when Tanuj says it, it's the truth. I'm looking forward to talk.
Thank you. I'm looking forward to listening to all of you. So that's why I joined early so that I don't miss anything.
Okay. Sometimes it's fun. The before the meeting, the small talk before the meeting, it's actually more fun.
Yeah, that's true. Otherwise, you don't get to talk in webinars. It's only the beginning time.
That's right.
Yeah, at the end, it's like they cut it. That's it.
Yes.
But whenever Tanuj asks, no one says no, right? He has that star power that he can attract all the speakers he wants.
Hi. Good evening, SK.
Hi.
Hi, SK.
Hi there.
Good evening.
Hi. I just changed my background.
Yeah. Sushma, have you got the background?
Oh, yeah. My laptop is not sort of accepting it somehow. I tried doing that, but it is getting all fuzzy.
Oh, dear. Okay.
SK, you have some slides for introduction. Are you giving some slides on APGS?
No.
Okay, fine.
Yeah. I won't have any slides. Yeah.
Okay.
So I'll just open shortly and then I pass over to you.
Okay.
So Tanuj, just for the content of my talk, I've really restricted it down to cataract surgery in non-ophthalmos because that's the most common thing. There's quite a lot to talk about even on that subject here. I've only got 8 minutes, so I've just kept it to phaco. I've got some good videos.
That's absolutely fine.
Mimi says she will join a bit late. She has some problem with the microphone.
So Dr. Kanchan has also joined us. Unmute, Dr. Kanchan, please unmute your.
Yes, am I audible?
Yes, you're audible. Do you want to check your slide share? Do you want to check whether it is working properly?
Yes, sir. Okay. Can I share my screen now?
Yeah, just test, share it and then stop share. We have 6 minutes. Yeah, you have to start from the titles, go from to the one slide before. Yeah.
Yes, sir.
Okay. And then you press the. You press here, you press on this display full screen.
Yes, sir.
Just press full screen once.
Yes, I pressed it. Right?
Yeah, so this is fine. Shamira, or you want to check your slides, Sushma, or Tony, do you want to check your slides?
Okay.
So, Kanchan, you can stop share.
Yeah.
Okay.
You have embedded the video is playing?
Yes, sir. I have checked everything.
So Dr. Kanchan is senior fellow with us. Finally,
excellent.
Very dedicated young budding clinician scientist.
Excellent. I look forward to meeting you all in March.
Yes.
February.
So I think back home.
In March, I'm going to RP Center.
Yeah.
Oh, okay.
So, Shamira, you want to check your slide share?
Yeah, that'd be good, actually. Yeah. Okay, I'll just show the video, just make sure it's working. If you please let me know if it's stuttering at all. Is it sharing?
Yes.
Slide share is there.
Perfect. Yeah.
Not full screen.
Not full screen. Okay, sorry. Let me just go to full screen. Okay, and let me know if it's working.
Yep.
Is it stuttering?
Perfect.
Is it smooth?
Yes, it's
very
working.
smooth.
Okay, I'll just flip to early later on. Is it clear?
Yep.
Yeah, it's clear.
Okay, that's fine. That's enough for me then. I'll let somebody else have a go if they want. I'll stop sharing now.
Okay, Sushma, you can share your screen and check.
I checked already, Dr. Tanuj, before you joined. The backend team was there.
Tony, do you want to check? Okay.
Okay, I'll share. Early birds.
So, SK, you are introducing all the Asia Pacific speakers, and I will introduce the Indian speaker. Is that okay?
Yes, yeah, okay.
And regarding Q&A, you can ask one question to each of the Asia Pacific speakers. I'll ask one question to the Indian speakers.
Okay, all right.
We had planned for 90 minutes, although they've allocated us 2 hours, but we can finish in 90 minutes.
Okay, good.
Okay, I think you guys saw it, right? So that's okay.
Yeah, that's good.
Okay, thanks.
Tanuj, how many people are logging on to this?
I have no idea because there are multiple societies. So there's a Cornea Society, Retina Society, New Zealand Society, Korean Society, the multiple sessions, multiple halls running.
Okay. Yeah.
And it's going live on YouTube also. I don't have, but after that, I'll give you the numbers.
Okay, that's great. Yeah.
Right now, I don't have.
I mean, you certainly got a good lineup of talks to scare anybody.
Yeah.
Is my voice okay? I mean, is it audible?
Voice is fine. Voice is fine. Hello, Dr. Manavdeep.
Hello, good evening, everyone.
Good evening, Doctor.
Hi.
Yeah.
So Manavdeep has just taken over as the Secretary of the Glaucoma Society of India.
Excellent. Congratulations, sir.
Thank you. Thank you, sir. Thank you so much.
Congratulations.
Thank you so much. And,
Manavdeep, you can introduce Sushma and Dr. S.S. Pandav.
Okay, okay.
I'll introduce Dr. Kanchan and Dr. Saurav Verma.
Okay, fine.
And you can also ask them one question.
Right. Okay.
So is anyone from the audio visual here?
Yeah, I think backend team is here.
Yeah.
One of the windows is showing up.
Yeah. Backend team, yes.
Yeah. They only helped me to check the slide share.
Okay. So is anyone from the audio visual team? Can you let us know, should we start the live session?
Yeah, it's exactly 6. Oh.
Yeah.
Yeah, actually.
I think we should be able to start. Why not?
Yeah, I will start.
Because multiple sessions are going on and it's a virtual thing and we don't have to wait for anybody.
SK, you can start off.
Okay. Are we ready?
Yeah, you can please start, SK.
Okay. Good evening, everyone. I'm Dr. Sing Kyong Fang, current president of Asia Pacific Glaucoma Society. I would like to thank Professor Namrata Sharma, Honorary Secretary General of All India Ophthalmic Society, and also Dr. Tanush Dada and Dr. Manavdeep Singh for gracing this international conclave together with Asia Pacific Glaucoma Society. So without further delay, I would like to pass this time to Professor Tanush.
Thank you, Dr. Fang, and thank you, Dr. Manavdeep, for joining us. We'll start off with the first talk.
Dr. Tanuj, I think although you are well known to everybody, but it's good that if I introduce you.
Okay, sure.
Dr. Tanu Dada is a very well-known international figure in glaucoma. He's an author of multiple books, and currently he heads the glaucoma of the Apex Institute of our country, that is Dr. Rajendra Prasad Center for Ophthalmic Sciences, All India Institute of Medical Sciences. So anything that comes out of his mouth is a word of wisdom, and it's a rule of law for of glaucoma in India. So he's that respected a person. So I request him to start off with the next.
That was very awesome introduction. Thank you. So our first speaker is our very young budding clinician scientist. Her name is Kanchan Gauri Satpute. She hails from Maharashtra, and currently she's a senior fellow at RP Center for Ophthalmic Sciences, All India Institute of Medical Sciences. And she has lost a lot of experience in goniotomy in primary congenital glaucoma. She'll be discussing the techniques and all the intraoperative problems, complications that can occur during this surgery and how to prevent them. So over to you, Dr. Kanchan.
Thank you. Thank you so much, sir. I'm just sharing my screen now. Okay. Is it visible?
Yeah, we can see.
Yes. So, good evening, everyone. I am Dr. Kanchan Satpute. I am a senior resident at RP Center. And first, I would like to thanks to my mentor and guide, Dr. Tanuj Dada, Dr. Namrata Sharma ma'am, AIOS and APGS. So after that, I am going to start this presentation. So my topic of presentation is complications of goniotomy in primary congenital glaucoma. Lights are not on. Excuse me. So I just want to give the brief introduction before I am going to start the actual procedure and the complication. So glaucoma in children is a treatable cause of blindness if diagnosed and treated in time. So the definitive management of primary congenital glaucoma is always surgical. So procedures generally we use are goniotomy, trabeculotomy, or combined trabeculotomy with trabeculectomy. So over the years, it has been widely debated which primary surgical method is to be performed for the patients of PCG. Now, goniotomy always scores over the other surgical procedures because it is minimally invasive surgery and without the need for conjunctival dissection and no long-term risk of bleb-related complication. Now, with conventional angle surgery, we could achieve the opening of only 1/3 or 1/2 of the angle. So what we are now doing is a 360-degree goniotomy. So why 360-degree goniotomy is important? Because it opened the entire angle in a single session. And nowadays, angle surgery is considered in terms of 360-degree. So we have also the published report. So this is one RP Center study, which was done with 360-degree trabeculotomy with microcatheter, and results are very good. And they concluded that this 360-degree trabeculotomy is better as compared to the trabeculotomy at the 1 year follow-up. But microcatheter is costly, so we tried this 360-degree goniotomy, which is done with either 20 gauge MVR, or we can use the needle, 24 gauge needle. So how this surgical technique is performed is the circumferential goniotomy, which is done first with the nasal goniotomy, and then we do the temporal goniotomy. So surgeon's position is shifted from nasal to temporal, in which we are doing small maneuvering of tilting of microscope and patient's head. So this gives a better visualization of angle. So now we'll see the video how this goniotomy is achieved. Am I audible? Am I audible?
Yes, yes.
Okay. So this is now we are seeing this nasal goniotomy is being performed, in which after making the side port and the with the use of this MVR blade, the goniotomy is done just above the insertion of iris. Now, similarly, this temporal goniotomy is going to perform. So in this, we have just changed the position from nasal to temporal. And now we are doing the similar goniotomy, which will be till the another end of nasal goniotomy is achieved. So in this way, we can perform whole 360-degree goniotomy with some maneuvering of this lens and the microscope. And the benefit is there is no need of repeated GA if second goniotomy is required. So the apart from this advantage, some complications are there which we noticed during goniotomy of our patient. So what we saw that there was no sight-threatening complication till date. So most common complication we noticed was the hypema. So this hypema was also not that severe. Most of the cases it got resolved in 2 days, or sometimes it was there for 3-4 days, but it resolved its own. We have not done any hypema drainage for goniotomy. The another complication was iris in side port, iris in goniotomy cleft, and scleral perforation. So we'll see all these complications one by one. So this was the first complication as I described, and this is the most common. Many times there can be minimal or no hypema, or sometimes there can be profuse hypema, but with after the irrigation aspiration and putting of the air bubble only take care of this hypema. So this is the another complication which we saw during the examination under anesthesia. So in all patients of goniotomy, we generally do the EUA at 1 month, and at 1 month EUA we saw this iris was stuck in the side port. So what we did, we gently removed this stuck iris from this side port, and again after injection of viscoelastic material, we perform the goniotomy. So here one take-home message is we have to do this side port little towards the corneal side so that iris will not stuck in the side port. So this was another complication. This was another complication which again we saw during the EUA, in which after goniotomy, after performance of goniotomy, what we saw, the whole of the goniotomy cleft was covered with this iris. So iris again goes and stuck into this goniotomy cleft. So as it was only 4 weeks back, which was done, the excessive fibrosis was not there. So we just injected the viscoelastic material, and with the cannula of this viscoelastic material, iris was gently pulled away or retracted away from this goniotomy cleft. And you can see the beautifully this goniotomy cleft was opened again. The patient was fine. The IOP was borderline. So we then planned for trabeculectomy in later date because the glaucoma was advanced glaucoma. So this complication actually we noticed when pilocarpine was not available. So another take-home message here is after the goniotomy, the injection of pilocarpine is very important because it will take care of this angle open. It keeps the angle open by pulling the iris away, and there will be no such complication. Then another complication was this scleral perforation. So this is a very rare and we saw only in one patient. So what was we noticed was during goniotomy, so this was a small child. It was a neonatal glaucoma. It was only 2 or 3 months old child. And the goniotomy was performed routinely. There was same instrument and all the steps were same. But what we noticed after removal of this lens, there was iris prolapse. So actually there was scleral perforation, full thickness, which we sutured with the vicryl, and the iris was gently pushed inside the AC, and the wound closed nicely with the vicryl, and the patient was then later planned for trabeculectomy. So all these are the complications we noticed during our goniotomy. But apart from that, goniotomy is a minimally invasive and very effective surgery. We also got the ethical clearance for our study, and we have done almost 40 patients of 360-degree goniotomy now. We will publish our data soon. So my conclusion is, with this 360-degree goniotomy, we can get the benefit of maximum possible IOP reduction in a single procedure. So many times if we are doing partial goniotomy and again pressure is borderline, so it's very difficult to decide whether to go for another 180-degree goniotomy or simply go for trabeculectomy. So this in this way, this is important, and IOP reduction and the results are really impressive. And thank you, my RPC team. Thank you again, Tanuj sir, Namrata ma'am, and Chief. Thank you so much for the opportunity.
Thank you, Dr. Kanchan. That is really a learning experience to see all these complications and learn from them. So one question for you is that after you make 2 side ports and do 360-degree goniotomy, there is a risk of leakage from the side ports and shelving of the AC. And once you get shelving of the AC, then the iris will go into the cleft. Yes, so how to prevent shelving of the AC in the immediate post-operative period if you do 2 side ports and 360-degree goniotomy?
Yes, sir. So 2 side ports we have to make for irrigation aspiration, and many times our ports are little larger, so we have to take care of AC formation by using this we can suture with the 10-0 nylon suture both side ports. Anyways, we are doing EVA of all patients, so we are patient is going to get under anesthesia after 1 month, so we can remove the sutures at that time, and there is no risk of or any increased risk of any infection or anything. But benefit of suturing is very much, because if AC is deep and iris is not going into the angle, then our goniotomy results are very good.
Thank you, Dr. Kanchan. Over to Dr. Manavdeep. Dr. Manavdeep, over to you.
Dr. Tanuj, I would just like to thank the Asia Pacific Glaucoma Society for doing this for us, and particularly yourself and Dr. Fang, as well as Dr. Manavdeep Singh, and all the speakers who could find time to be with us today here. Thank you so much.
Thank you, Dr. Nanda. Thank you so much.
So next speaker is Dr. Sushma Tejwani. She is from Narayan Nethralaya, Bangalore, and is a very versatile speaker and surgeon. She can talk on any topic of glaucoma, and she's a great researcher. So over to you, Dr. Sushma.
Thank you so much, Dr. Manavdeep. You're being very kind to me. I'll try to share the screen. Well, at the outset, I would definitely like to thank Dr. Tanuj Dada and Dr. Namrata Sharma and APGC and AIOS for giving me this opportunity. So I have put together a case and certain tips for taking care of bleb rupture during phacoemulsification. It has a voiceover, so I'll be just playing that. This video demonstrates intraoperative bursting open of a filtering trabeculectomy bleb during phacoemulsification and its management. A 45-year-old male presented with decreased vision in both the eyes and had history of trabeculectomy bilaterally 15 years back. Right eye was blind since then. In the left eye, there was high filtering thin bleb, nuclear cataract with hypotony along with advanced glaucomatous cupping. Left eye was the only seeing eye and the optic nerve appeared pale with hazy view of macula. There was advanced visual field loss even on 10-2 program. The bleb OCT showed large hyporeflective area suggestive of high filtering bleb and a thin bleb wall, as thin as 20 microns at some places. He was advised left eye cataract surgery under guarded visual prognosis. Situations like this amount to almost like walking on a tight rope where a little imbalance on either side can be disastrous. Hence, due precautions were taken even while giving peribulbar block to avoid undue pressure. While draping, speculum was applied gently to ensure safety of the bleb. To begin the surgery, the side port incisions were made, avoiding the bleb area. Viscoelastic was injected to form the anterior chamber. A continuous curvilinear capsulorhexis was performed using a bent needle cystitome through the side port. A temporal clear corneal incision was made using a 2.2 mm keratome. Hydrodissection and hydrodelineation were performed with slow fluid waves, thereby avoiding possible intraocular pressure rise in the anterior chamber. Nucleus was freely rotated in the bag. Phacoemulsification was performed with low fluidics parameters, that is a low bottle height and a slower aspiration flow rate. A stop and chop strategy was employed to crack the nucleus, followed by aspiration of nuclear fragments. All these maneuvers were done keeping the fluidics low and being gentler to avoid inadvertent trauma, keeping a watch on the bleb. All was going well, but then there was a sudden change in the situation, like bursting of a balloon. And yes, the bleb gave way. As the epinuclear plate was being aspirated, a sudden fluid jet was noted through the bleb. However, the chamber did not collapse totally. This happened probably when occlusion broke suddenly at the tip of the probe. This suggested that some weak area of the bleb wall had given way to the fluidics pressure in the chamber. The procedure was continued with the aspiration of epinucleus and cortex with further lower parameters. This was followed by implantation of a foldable intraocular lens in the bag. Viscoelastic was then removed and the anterior chamber was formed again with BSS. The site of leakage was identified and the quick swelling up of cellulose sponge suggested a significant leak. The margins of the defect appeared too fragile to be held, as the avascular tissue would give way, leading to a larger defect. Hence, I decided to use fibrin glue instead of sutures.
The anterior chamber was filled with air to keep the area of leak dry. A preserved amniotic membrane graft was immediately called for and fashioned to the required size. Both the components of fibrin glue were applied over the bleb. The amniotic membrane was immediately transferred over the bleb with stromal side facing down. After waiting for a couple of minutes for glue to dry, the excess graft tissue overlying the cornea was excised to keep the visual axis clear. The graft was then anchored to the surrounding healthy conjunctiva with atovicral sutures. The graft margins were kept away from the bleb margin in order to avoid any further injury and to achieve a secure attachment of the graft. At the end, surface and free limbal margins were again checked to ensure that there is no leak. Also, a formed anterior chamber was confirmed while removing the speculum gently. On first post-operative day, the patient was doing well with a quiet eye and a formed anterior chamber. A Seidels test was performed at 2 weeks to detect any micro leak and was negative. Fundus was clearly visible, CD ratio appeared 0.6 with pallor, and the bleb OCT was carried out again that showed a shallower hyporeflective space with somewhat thicker bleb wall. At 2 years follow-up, the bleb maintained filtering function with a deep anterior chamber. The intraocular pressure remained in the range of 5 to 10 millimeters of mercury and the visual fields were stable. Thus, with early identification and proper intervention, a young patient was saved from devastating outcome and a potential blindness. The other methods of salvaging such blebs with larger areas of leak could be conjunctival autografts using various techniques and also scleral patch graft in certain situations. For example, in this patient, the conjunctival incision was made around the bleb in healthy conjunctiva and blunt dissection was performed to advance the conjunctiva. To cover the bleb completely, a relaxing incision was given and VY plasty technique was used to anchor the conjunctiva over limbus to cover the whole bleb area with healthy conjunctiva. However, as shown in this video, the conjunctival advancement was not sufficient. Hence, a conjunctival autograft was harvested from the nasal area and the bleb area was covered with the free flap before proceeding with the cataract surgery. In a situation where there is a full thickness defect causing leak, a scleral patch graft can be used to close the area followed by conjunctival coverage. In nutshell, to avoid such situations, one should be mindful regarding handling of the thin blebs while operating. A careful peribulbar block using low fluidics, avoiding fluctuations in the chamber can avoid bleb rupture while doing phacoemulsification. And in case it happens, one should not panic and plan for minimal possible intervention to close the leak. Avoid suturing in avascular areas. Small leaks can be addressed with glue and amniotic membrane. Larger leaks may require conjunctival autograft and even cadaveric scleral patch graft in extreme situations. Thank you for your kind attention.
Thank you, Dr. Sushma. That was indeed a wonderful presentation and your wonderful management of this difficult case. However, I would like to ask you that have you become wiser after having faced this complication? I mean to say, having faced this complication, what is your learning experience and how will you like to do the bleb management in this kind of a case if you face this kind of a case in future, or for all of us to learn that you will like to recommend that pre-operatively should we do some management of a very thin bleb in a one-eyed patient, because we do face this kind of patients. So would you recommend any pre-cataract surgery procedure before undertaking surgery on this kind of patients?
So as a routine, if I see any thin MMC blebs which are looking very fragile and may give way during phacoemulsification, I definitely do an ASOCT to measure the wall thickness. And I make sure that in my OT that day, amniotic membrane and donor sclera is available in case I require. And I always take a consent from the patient that I might have to take a conjunctival graft. So, and other than that, while performing phacoemulsification in these patients, I always keep my parameters low. That makes my surgery slow, but I'm more comfortable that my blebs would not give way.
No, my question was slightly different. Would you like to do some kind of a, bleb management pre-operatively? Maybe some kind of a conjunctival, you can excise all this conjunctiva, which is now not actually, it's all avascular. And would you like to do that kind of a bleb management, or would you like to do a amniotic membrane grafting beforehand?
Actually, somehow, if the bleb is functioning and the patient has been managing for long, I don't like to touch those blebs. Unless I see the complications like hypotony or there is a leak beforehand. In those patients, like I showed you those 2 clips in the end, where I had managed the bleb and then did the cataract surgery at the same sitting, because one of the bleb was already leaking and the second bleb patient already had hypotony, maculopathy, and that was showing a sort of bleb sweating. So unless there is something in the bleb which needs repair, I usually do not do anything pre-operatively. I may learn from all the speakers and you that if there is anything that we should do beforehand in such situations.
Dr. Tanuj, please, it's over to you, and if you can reply this.
No, I think what you were asking was whether we should do the bleb repair and then plan for cataract surgery. Yes, so if the ASOCT shows a very thin conjunctiva and if there is a mitomycin C induced force Seidel test which is positive, and if I am of the opinion that this bleb is going to leak, then preoperatively I will do the conjunctival repair and defer the cataract surgery beyond 6 months if the patient other eye vision is good. So that is another option that is available. But I think what Sushma showed, there was a balance between the both. So the bleb functioning was appropriate and she could salvage the bleb just with minimal amniotic membrane. So these are both the options that are available to the surgeon. And I just want to thank Dr. Namrata had just joined us, because this is the first time we are having 3 societies, the Glaucoma Society of India, All India Ophthalmic Society, and Asia Pacific Glaucoma Society together, all the members coming for a meeting and sharing their experience and views. And I'm very happy that Dr. Manavdeep Singh, who is head of ophthalmology at prestigious Ram Manohar Lohia Hospital, New Delhi, and current secretary of the Glaucoma Society of India, he has joined us to convene this session. And also we have the president of Asia Pacific Glaucoma Society, Dr. S.K. Fang from Malaysia, who is going to introduce the speakers from the Asia Pacific region. So I hope we'll have more such activities. So over to you, SK, for the next talk.
Thank you, Tanuj, and also thank you, Professor Namrata and Dr. Manavdeep. It gives me great pleasure now to introduce our next speaker, which is Associate Professor Shamira Pereira. He's from Singapore National Eye Center, and he's also co-head of bioengineering and devices division at the Singapore Eye Research Institute. And he has actually interest in surgical devices and has actually have a few patents already out from his biomechanics and also in surgical devices for glaucoma and cataract surgery. And he has also had award-winning free app module called Touch Surgery. And I would like to now invite him to speak on surgical challenges in nanophthalmos. And because of time, he will just concentrate on phacoemulsification in nanophthalmos. Over to you, Shamira.
Thank you very much, Tanuj, and SK for the very kind introductions. So I'll be speaking on phaco in nanophthalmic eyes. It's great to be here at this meeting. These are my financial disclosures, none of which are relevant to today's talk. Now, Non-ophthalmic eyes often develop angle closure in the rate of between 54 to 77%. And this is because of the relatively large lens in a small eye. There are multiple mechanisms at play here, but what we do know is that lens extraction relieves the angle closure very well in non-ophthalmos. Unfortunately, the visual outcomes after cataract surgery in non-ophthalmic eyes are highly unpredictable due to refractive surprises and because of macular changes after the surgery. Now, while some people do disagree about the anatomic classification of non-ophthalmics, most people would say that it counts as any eye with axial length less than 20.5. There are other features as well that they have in common, typically a small cornea, the shallow anterior chamber depth, marked iris convexity, and they suffer from uveal effusions quite commonly because of the thickened sclera and choroid. Here's an example of two UBMs of eyes I've seen in Singapore. One is a +17 diopter refracted patient with a 5mm lens in a 15.2mm eye. And you can see on the UBM, you can actually even measure the sclera at 2mm thick. Here's another eye with 15.4mm axial length and a swollen lens with a thickness of 5.2mm. You can see the engorged vessels and the crowded disc at the back. And this is the eye that I'll be showing you the phaco of later on in this presentation. Now, we know there are several intraoperative difficulties and precautions that you must take for these eyes. First things first, you have to get your corneal incisions right because tight wound construction and small incision length are very important to providing a stable anterior chamber. This anterior chamber must be monitored at all times and refilled with viscoelastics regularly to maintain the anterior chamber depth. If you don't, and there is any drop in pressure, you can have a serous or hemorrhagic choroidal detachment, or even a suprachoroidal hemorrhage. For this, you will need to perform a sclerectomy, and some people recommend a prophylactic sclerostomy, but more about that later. Because of the shallow anterior chamber depth and the risk of endothelial cell loss, some people also propose a soft shell technique with a dispersive cohesive viscoelastic. Now, my tips that I particularly use are, and I think these have been well recognized as quite commonly used by other surgeons, is the use of topical intracameral anesthetics for the surgery. If you're going to use a peribulbar, try and not use too much fluid because these eyes typically have a small orbital size and also small palpable aperture. So you might be making things more difficult for yourself if you put in too much fluid. I routinely use 20% mannitol to keep the pressure in the eye down, and I use clear corneal temporal incisions with heavy use of Helon GV or Helon 5 to maintain the AC. I prefer to do the capsulorhexis with Kawai force, which is a smaller gauge, and do not shallow the AC like the Utratus may do. And always making time out to preemptively watch for iris prolapse. Now, there are several controversies about these eyes as well. Some people do like to perform a limited pars plana vitrectomy to give themselves some space in the anterior chamber, but you have to be very, very careful with this. And I'm not a fan because you can go straight through into the retina if you do this because of the non-existent pars plana. In terms of sclerotomies, I again prefer not to do these until absolutely necessary if there is some shallowing because of the formation intraoperatively of an effusion. But I'm ready for it because I do like to perform sclerectomies, especially in those eyes that have had previous uveal effusions. I prefer to do them square in shape and at the start of the operation. And you do find that actually it does deepen the anterior chamber. In terms of the suturing of the wounds, I prefer to do that because you do want to maintain the integrity of the globe and you don't want any AC shallowing through any leaks. Now, PCRs are very common. As you can see in one study, it showed that in non-ophthalmic eyes with axial length averaging around 20 millimeters in length, they were getting 11.7% of PCRs. And this increased up to 25% in those eyes that are shorter than 17 millimeters. Here's an example of one case, and you'll see me performing a sclerectomy here. This is a 15.4 millimeter non-ophthalmic eye, in which case there were previous effusions. In fact, the other eye lost vision completely because of uveal effusions. So this is the only eye, and I'm performing these square-shaped sclerectomies around about 90% depth. I've measured the thickness at about 2 millimeters, and I'm doing these about 4 millimeters back. It's harder to get decent sizes on these because there's just not much space to move. As you can see, I'm very, very close to the choroid there, and if necessary, I can just plunge through by cut down and relieve any fluid that's accumulating in the suprachoroidal space. There was one such study that looked at randomizing patients to a sclerostomy versus no sclerostomy. And although it's small numbers, you can see that there were actually less complications in the sclerostomy group. This didn't quite achieve statistical significance though, but the idea it being that it allows any accumulated suprachoroidal fluid to leak out. Here's me performing the remainder of the operation. You can see that I'm performing an initiation of the capsulorhexis with a needle here, and I'm always wearing of the capsulorhexis tearing out, which is a common thing that can happen in these eyes. I'm using a Kawai forceps, which is a small gauge and doesn't allow showering of the anterior chamber. I've done the sclerectomies already, and the AC has deepened. Here, I'm watching out for iris prolapse, and I've put in specifically these iris hooks to keep the pupil size bigger. The phaco goes well, and I put in the lens here, which is a acrylic lens. At that point, I actually have a look at the fundus to see if there's any uveal effusions forming that aren't, but I've probably taken too long over it. And when I come out, I can see the AC shallowing. And that's why I put some extra sutures in the wound to maintain its integrity there. In terms of the refractive outcomes, you can see that there are complications with unpredictable refractive surprises. You can see in this studies, both have shown greater than 40% of eyes achieve a refraction within 1 diopter of the target refraction. They use the SRKT here. And actually, against what we were taught previously, it seems that the Hoffa-Q doesn't do so well in these eyes. The best one is the Kane formula in one study, and then the Barrett does well as well. In terms of the IOL choice and placement, you can go for 2 options, either both implants in the bag or piggyback, which means one in the sulcus. The both in the bag does suffer from some problems with intractable interlenticular membranes and a late hypertrophic shift because of a contraction of the bag. But the aim here is used for different materials. If you're going for a single lens approach, which you can do, single lens in the bag, then you can use a Mortuer lens, which offers a very high dioptric power, up to 75 diopters, but it has a large incision size, which is a negative thing. The Zeiss Extreme D is a very popular lens that covers, again, a very large dioptric range, and this is very commonly used. The Alcon SA60, which is what I use in this case, goes up to +40. That can be very useful for placement in the bag, and then you've got another lens for the sulcus. This is what these piggyback lenses look like in the longer term. I use this Hiksoak Pro lens calculator for multiple lenses, and that tells you exactly what power lens to use for the bag and then which one to use for the sulcus as well. From lenses in the sulcus, you've got about 3 options: the Sulcoflex, the Sensar, and the Star lens. And the Sulcoflex is specifically made for the sulcus and has these undulating haptics, which don't cause much damage. It has a very large optic size and a posterior concave surface. The AMO Sensar lens has this opti-edge rounded front, which is meant to reduce the amount of pigment dispersion. And you've got this very, very thin Star lens, which is made of silicone, very soft material, again, which is very atraumatic. In terms of complications, we know that these are greatly increased in this difficult, challenging eyes. And in one study, there was malignant glaucoma occurring in almost 10% of cases, vitreous hemorrhage in another 10%, and vitreous hemorrhage and retinal detachment in almost 5%. So that's a very high rate of complications. In another study, which actually employed a PI and an anterior vitrectomy in many cases, they were still getting 7% of PCRs occurring. So in conclusion, we really need to use our imaging and surgical technologies, and these are improved outcomes for such challenging eyes. Ophthalmic eyes do represent a significant surgical challenge and a high rate of intraoperative complications. Fortunately, the unpredictability of IOL power calculation has been worked around with better formulae. Thank you very much.
Thank you, Shamira, for excellent overview of phacoemulsification in non-ophthalmic eye. Just 2 questions for you. Which do you prefer, and what is the advantage? You prefer sclerectomy? How about just sclerostomy? And how many quadrants do you do?
Right. So for this patient, they had actually 2 uveal effusions that were inferior in the past that resolved over time. So those are the ones that are most likely to occur again. So thence I placed 2 sclerectomies in that area. And I was ready to use an MVR blade to cut down if I got them appearing on the table. But I wouldn't go as far as putting them in preemptively, only if the AC did start to form. I use square ones at around about 4 millimeters in size. Some people advocate larger ones, but realistically, it's actually very hard to find space to go and make anything larger than 4 millimeters square.
How far back do you go?
About 4 millimeters back. And the idea is that it will reduce the tension on the vortex veins. And by doing so, you get lesser formation of these uveal effusions. And in actual fact, it actually deepen the anterior chamber for me.
Thank you, Tanush. Thank you, Shamira. I would like now to introduce the next speaker, which is Dr. Joseph Anthony Tumbokon, who is also one of Asia Pacific Glaucoma Society board members. He is the head of the Glaucoma Service, assistant head of the undergraduate education department of St. Luke's Medical Center in Manila, Philippines. And he's also the past president of the Philippine Glaucoma Society. Today he will be talking to us on repair of recurrent tube exposure. Over to you, Tony.
Thank you, SK. Again, okay. Are you seeing my slides?
Yes.
Okay. So, thank you, SK, for the introduction. I would like to thank the All India Ophthalmologic Society and the APGS for inviting me to give a talk in this session. Now, my talk for this evening is repair of recurrent tube exposure using amniotic membrane conjunctival autograft sandwich. I'll describe this later on in detail. This is my financial disclosures, none of which are relevant to this talk. This is my outline. I'll first briefly go into the incidence of tube exposure, how we could prevent them, and how to manage them using the technique I mentioned earlier. Now, if you look at the AVB, ABC, and the TVT studies, the incidence of tube or plate exposure ranges from around 1 to 5%. It's not that common, but if it occurs, it could be quite problematic. It's important that we prevent them from occurring in the first place, but if you do a lot of surgeries, you have a tendency to see one of these, and we need to know how to manage them properly. For preoperative planning, we want to make sure we identify those patients that may be at risk for tube or plate exposure. And these are patients who have extensive conjunctival scarring, thin sclera, presence of ocular surface disease, dry eye, or eyelid malposition. We want to correct any of these reversible risk factors so that you will have decreased the chance of having any tube or plate exposure. Of course, if the patient has diabetes mellitus, you want to make sure that it is controlled before undergoing surgery. To prevent tube or plate exposure, we have to make sure that the plate is positioned properly and secured 8 to 10 millimeters posterior to the limbus. We enter at the correct point, and the trajectory of the tube should be around 8, should be parallel to the iris plane. We want to make sure that the anterior subconjunctival portion of the tube is covered properly, either here, like in this case, a scleral flap, some form of patch like tutoplast or scleral patch graft. And of course, closing the conjunctiva properly, making sure that you won't have any delent formation and it's quite smooth and closed in a quite tidy manner. Now, in this case that I'm going to show, this is a patient who already had a tube around 10 years prior. Patient was a 36-year-old female. Patient had the juvenile onset glaucoma and also cataract. She's already pseudophakic. After around 10 years, the pressure started going up. We decided to place an inferior nasal tube. However, the tube got exposed just after around 4 to 5 months post-op. So in this case, we first decided to do a conjunctival rotation. We did extensive conjunctival dissection and then dissected it to make sure that the healthy portion of the conjunctival will be covering the tube. We also placed a scleral patch graft and then rotated the conjunctiva nasally. As you could see here, healthy conjunctiva covers both the tube and most of the scleral patch graft. However, after 3 months, we had the recurrence of the tube exposure. We noted that the conjunctiva was a little bit quite tight, and this may be causing tension and leading to the exposure. So we decided to use a conjunctival autograft to cover the exposed tube and also put another patch graft. However, a free conjunctival autograft doesn't take well when you place it on top of sclera. So in this case, we utilize a double layer amniotic membrane and it's sandwiched on the conjunctival autograft. As mentioned earlier in the previous talk, amniotic membrane is usually placed on a nitrocellulose paper with the epithelial membrane, epithelial side up. And it can be used as a patch wherein the epithelium is placed epithelial side down, or as a graft wherein the amniotic membrane is placed epithelial side up. So if you want to do an amniotic membrane sandwich, you place it the first layer epithelial side up and the upper layer epithelial side down. In this case, we place the conjunctival autograft in between the patch, the amniotic membrane patch, and the amniotic membrane graft. So this is the surgery. So we did dissection. As you can see, even the scleral flap has already melted away. So we let the conjunctiva hang back. There was quite a bit of tension. And then place a scleral patch graft to cover most of the defect over the tube. And then this is the amniotic membrane on the nitrocellulose paper. We place it epithelial side up. So this will serve as a scaffold for the conjunctival autograft. And then sutured it with a 10-0 nylon at the limbus. And then we tucked in excess amniotic membrane underneath the conjunctiva, then sutured the amniotic membrane onto the sclera and onto the conjunctiva. After which we measured the size of the defect, then harvested the conjunctival autograft superinasally. And then just flipped it over the conjunctiva. Flip the conjunctiva over the cornea. Then cut it. And then just rotated it at the area of the defect, making sure that it's limbus to limbus. And then now the conjunctival autograft is epithelial side down. We sutured it onto the limbus and then just flipped it over. And then secured it using 10-0 nylon sutures in an interrupted and continuous running suture technique, making sure that the conjunctival autograft is well coaptated with the inferior nasal conjunctiva. Now, again, the amniotic membrane graft will serve as sort of the scaffold. Now here's the amniotic membrane patch. It will help protect the conjunctiva from trauma and make it heal a bit better. So we just fixated this with 10-0 nylon sutures and 6-0 vicryl sutures into the conjunctiva. This patch will eventually melt away after around a few weeks, and then it will leave the conjunctiva quite healthy. So in summary, I just described a technique of how to repair a tube exposure using an amniotic membrane conjunctival autograft sandwich. It's a viable technique for those repairing, if you want to repair recurrent tube exposure, where conjunctival advancement or rotation is not feasible. Again, prevention is really the key, and individualized preoperative planning and meticulous attention to proper surgical technique will help decrease the risk. Thank you very much for your attention, and I look forward to some discussion.
Thank you, Tony, for describing a novel technique for a difficult problem. I find that, as you say, prevention is probably the key, the way that you insert the tube. But once you have a tube exposure, I would say that the best option is to reposition the tube. What do you think of that?
Again, knowing what the cause is, especially if there's a little bit of irregularity, then you need to do some repositioning of the tube. In this case, I think we didn't do that. The eyelid, there was a little bit of scleral show inferiorly. So I think that contributed to the tube exposure. If you think that the position of the entry of the tube is the one that's causing it, then repositioning is quite important. It's always important to make sure that you look at the root cause of the problem and address it properly, or else it will just recur. In this case, we had an exposure. We thought we did the conjunctival rotation. However, it was too tight. Even though with the extensive dissection, it was too tight that it was the exposure just recurred.
Thank you, Tony. I would like now to introduce the next speaker. Welcome, Astrenda. Dr. Astrenda Suryono is a glaucoma staff at the Department of Ophthalmology, University Indonesia, and also Cipto Mangunkusumo Hospital in Jakarta. And she did her glaucoma fellowship in both in NUH and also in Moorfields. And presently, she's the regional secretary for Indonesia to the Asia Pacific Academy of Ophthalmology. She will be talking to us on managing hypotony post-tube surgery. Over to you, Astrenda.
Thank you, Dr. Fang, for the kind introduction. And I'd like also to thank the AIOS and the APGS for inviting me in this meeting. So my talk today will be about hypotony in post-tube surgery. So as a definition, ocular hypertony is normally an intraocular pressure that is 3 standard deviation below normal or an IOP low enough to cause visual impairment. And the manifestation can include maculopathy, corneal edema, astigmatism, choroidal effusion, and or accelerated cataract formation. The incidence is quite varied, especially in filtering glaucoma surgery, but in glaucoma drainage device, some studies, for instance, the Indian study studying the AIDI, the number of hypotony is probably 7% in adult and 6% in pediatric groups, whereas in the AGV is slightly lower because it's probably a valved tube. It's around 3, and it's slightly higher in the Barfeld tube at about 16.5. And the 2 most commonly used drainage implants probably in the world so far is the Ahmed tube and Barfeld implant. And the valveless device such as the Barfeld are more liable to cause hypotony and require temporary tube ligature to control IOP until the plate is encapsulated or has some fibrous tissue. Now I'd like to talk about 2 types of hypotonia. Probably the early types of hypotonia are due to early leak from the tube entry, excessive flow through the valve device in result of overpriming, and incomplete tube ligation in the non-valve type of tube. And also severe inflammation may cause hypoproduction of aqueous. And this probably we can prevent by cautious tube priming or using smaller needle to make the tube entry. And we can also insert some viscoelastics such as the sodium hyaluronate intracamerally and the use of steroids to help the severe inflammation. But unfortunately, sometimes there are the persistent or late or chronic type of hypotonia. And probably some populations are more prone to these types of persistent or chronic hypotonia, especially in probably aging cases or ciliary body dysfunctions. The prevention, if we know that we're operating probably on these more susceptible individuals, we might want to use smaller surface area for the tube, and we do permanent ligation. And postoperatively, if we find any hypotonia, we might want to check, we might want to do some tests, whether there's leak, we can do a Seidel's test, or we can see the the fluid flow on the posterior side with ultrasound by microscopy. Management has been described in recent studies, which includes watchful waiting or injection of OVDs intracamerally. And also some surgical options are described, such as the ligation of the tube, intraluminal stents, and probably removal some parts or maybe all of the plates. So the up-internal tube ligation is described by Fergados. This technique is quite meticulous, but may work for hypotony in cases where we need to ligate further and reduce the flow in the plate. So this technique describes two ligation using 9-O-proline in two different locations, the ones that are anterior and posterior in the intracameral part of the tube. This procedure aims to reduce intraluminal diameter of the tube without total tube occlusion. And the result is, in the 2 years result, it's resolution for the hypotony with no significant rebound IOP rise in most of the cases. Although there is some concerning complication, including the inferior displacement of the intraluminal stents may irritate the corneal endothelium and cause corneal decompensation. Another technique described to resolve hypotony is probably to put a bent intraluminal stent. This procedure is described when two suture threads were bent to the angle of 30 to 50 degrees and inserted them into the drainage implant to increase the IOP. It provides larger tube occlusion than tube ligation, and it doesn't affect the tube curvature. Another procedure that you might want to consider is making plates smaller. For instance, in this study, it's excising the Barveld wings and suture ligation of the tube. This may be effective in achieving rapid reversal of hypotony while providing flexibility in postoperative IOP management, and reducing the size or surface area of the scleral explant and therefore the surface area of the surrounding fibrous capsule at the time of surgery may help preventing the recurrence of hypotony following the ligature release. I'd like to share with you some case illustration. And this is a 25-year-old lady. She complains of blurry vision 4 months prior to coming to the office. And she complains of decreased visual acuity, especially on the left eye. And she described it like peeking through a keyhole. There was no past history of any other conditions. And she came already with some medications, acetazolamide orally, and some 2 types of glaucoma eye drops. Her visual acuity upon first presentation was still 6.6 on both eyes with maximum medication and controlled IOP with quite an advanced cup to disc ratio. This is her first OCT examination, showed thinning in both eyes, but the visual field was especially severely affected on the left eye, and the right eye has some degrees of visual field depression. That time, the patient was diagnosed as a juvenile glaucoma, and we initially had plan for trabeculectomy for both eyes. And then 6 months post-op though, she complained of decreased vision, and as expected, the pressure has risen and we have to put her on maximum medication to control her IOP. So we put her on medication for about a year, and then she complains furthermore about worsening vision for both eyes. And at some point, she had a range of 18 to 25 millimeter mercury for the right eye, which is the best eye, and then left eye was well controlled with glaucoma medications. But because the right eye is the good eye, we want to lower the pressure. So we set the target lower and we plan to do an implant. At this point, we decided to do a Firna implant, which is a non-valved GDD on the right eye. So during her post-operative period, the first 3 months, she has quite a nice IOP, well controlled. Sometimes we need to add 1 drop or 2 drops, but still managed to be controlled. But strangely, on the 4th month after the surgery, the pressure dropped into 4. So we decided to give her some steroids treatment, including topical and oral. And we did some examination that exclude any choroidal effusions or any choroidal detachment. So this is the picture of her macula. We can see that there's a severe folds around the macula, and resulting in maculopathy hypotony, and visual acuity dropped to 620 uncorrected on the right eye, and pressure was ranging between 4 to 8. We consulted the retinal division for any treatment that they might suggest to us, but they decided to do a conservative treatment and just watch while giving the steroid treatments, probably because this is the best eye, so they were very careful on deciding to do any further surgical intervention. So OCT also showed some condition, the maculopathy condition with folds and some elevated thickness. Thankfully, after 1.5 months of aggressive steroid treatments, the visual acuity improved, and this is her latest, her last macular picture, showing still some folds, but not that severely, not as severe as our first picture. And the OCT has shown some great improvements as well. But unfortunately, this better condition is at the price of eye pressure rising. So pressure at this point was 29, and we have to give her medications as well to control it. So yeah, as a take-home message, hypotonic is a difficult and challenging situation, maybe traumatic also for the surgeon, and may result in devastating visual prognosis for the patient. Management is timely and must be carefully considered. Surgical options may be needed and requires meticulous technique. So it is important to consider safety and efficacy for surgical options, and maybe learning from experiences. Sometimes watchful waiting may have a place, and outcome also might be good, such as in this patient. So with that, I thank you, and I will take questions if there's any. Thank you.
Thank you, Astrenda. One question, if you have hypotony due to over drainage of a non-valve implant, just for example, bowel, how would you do the stenting if you want to stent? Yeah.
Yes, I believe that the literature says that stenting, we need to do intracamerally. We make some extra port, second port, and we introduce the stenting, maybe using 6-O-proline or 7-O-proline, depending on what's available, I think, in my center. And we inserted it in the AC, but I don't have an experience of that, Dr. Fang, not yet, because our patients, it's either still very good vision, just like the case illustration that I did. I mostly just watchful waiting and give steroids. But in some severely hypotony, and if I've waited long enough, but the pressure is not rising, some cases I did explant tube. But in these cases, I choose probably the ones who have very poor visual prognosis.
Okay. Yeah, I agree. But the stenting with I think 6 or 7-O-proline is small. I think for Bawel or Ahmed, we need at least 3 to 4-O-proline, and we can actually do it as you described, intracamerally, or sometimes you can just do a corneal incision over the tube, temporary externalize the tube, put in the stent, and replace it into the anterior chamber. Thank you, Astrenda. We have probably some discussion at the end. Over to you, Dr. Manavdit, to introduce the next speaker.
Thank you, sir. It's my privilege to introduce Dr. S.S. Panda, who is the immediate past president of Glaucoma Society of India, and he heads the Advanced Eye Center at Postgraduate Institute of Medical Education and Research at Chandigarh. Over to you, sir.
Dr. Pandav is actually having some problem in the projection, so he has requested to delay his talk by a few minutes. So is Dr. Mimi and Dr. Saurav Verma online?
I'm here, sir. No.
Is SK Dr. Mimi is joined? Will be joining us?
Yeah, I will text her. Yeah.
Okay. So Saurabh, you can share your presentation.
Sure.
So Dr. Saurav Verma is a assistant professor at RP Center for Ophthalmic Sciences, All India Institute of Medical Sciences, and he's an AIOS clinician and a vitreoretinal surgeon. And over the last 6 months, we have had 3 cases of suprachoroidal hemorrhage after trabeculectomy, and all 3 cases were managed, and one of the cases, despite management, went into phthisis bulbi. So I thought this is a very important complication which should be highlighted to all the glaucoma fraternity. So Saurav will be discussing how to manage and how to prevent the occurrence of suprachoroidal hemorrhage after glaucoma surgery. So over to you, Dr. Saurav.
Thank you very much, sir, for the kind introduction. I'll be discussing about management of suprachoroidal hemorrhage post glaucoma surgery. Is my screen visible to you?
Yeah, screen is nicely visible.
Okay, so it is collection of blood in suprachoroidal space due to rupture of long or short posterior ciliary arteries. And filtration surgery is one of the most common ocular surgery to be associated with suprachoroidal hemorrhage. The incidence is very low, varying from around 0.7 to 2%, but it is still significant. It occurs due to high preoperative IOP, which drops suddenly intraoperatively. So there was a major study by Waziri et al., which evaluated the incidence of post-operated suprachoroidal hemorrhage after glaucoma filtration surgeries in about 17,800 trabeculectomies and 9,500 tube surgeries. And they found out that the risk of suprachoroidal hemorrhage was almost twice as high in the tube group. A similar study by Tully et al. Showed that the incidence of suprachoroidal hemorrhage is increased with the use of antimetabolites and non-valved tube shunt implants. Other important risk factors include white race, use of anticoagulant drugs in the preoperative period, severe postoperative hypotony, presence of aphakia, ACIOL, or myopia. In the preoperative period, we have to bring down intraocular pressure and blood pressure to the normal limit. If possible, and the patient is on anticoagulants, then we should try and stop the anticoagulant drugs. During the surgery, we have to manage the blood pressure and the cardiac rate. And also the patient has to be instructed to avoid severe bouts of cough if possible. In the post-operative period, again, patient is to be instructed to avoid all forms of trauma and avoidable straining. And inflammation and hypotony, if present, is to be managed accordingly. Signs of intraoperative suprachoroidal hemorrhage include increased IOP, sudden change in red reflex, and vitreous prolapse. And if suspected, prompt closure of the surgical site is warranted. Presence of pre-placed scleral flap sutures might really help in this scenario. If the globe contents are expelling, we can try and reposit them, but we might actually have to compromise this tissue, cut this tissue away so as to achieve rapid resuturing of the ostium. And in some cases, you can also try to drain suprachoroidal hemorrhage right on the spot to reposit tissue, but it is generally not recommended. In the post-operative period, patients present with intense pain, decreased vision, slit lamp examination, and indirect ophthalmoscopic examination helps in confirming the diagnosis. So ultrasonography has a very important role to play in the diagnosis and management. It is helpful in localization and marking the extent of expulsive hemorrhage. It can also help in assessing the state of clot lysis. So in the first image, you can see there is blood in the suprachoroidal space, but it has high internal reflectivity, which is suggestive of clotted nature of the blood, which would be difficult to remove. But in the second image, there is low internal reflectivity in the suprachoroidal space, which is suggestive of lysed blood, which would be relatively easy to remove. Generally, it takes about 10 to 14 days for the blood to lyse. So this is the ideal time at which suprachoroidal drainage, if needed, should be attempted. Early drainage may be required in cases with high IOP, intolerable pain, flat anterior chamber, a coexisting retinal detachment, deteriorating vision, or in the presence of kissing choroidals. So while you are following up these patients in the first week or so after the occurrence of suprachoroidal hemorrhage, you have to assess two things: liquefaction and the height of CD. If the height of CD is reducing on its own, then you don't need to intervene. But if the height is increasing or the patient has progressed to a state of kissing choroidal, as seen in the first image on the ultrasound, then we have to intervene surgically. If there is no coexisting vitreoretinal pathology, then external drainage through sclerotomy would be sufficient. So the conventional technique of drainage is via sclerotomy. This was a patient who had developed suprachoroidal hemorrhage. The maximum height of the mound was noted to be in the inferior nasal quadrant. We have already done a localized peritomy and hooked and bridled the muscles to bring about proper exposure of the area. Now we're making an AC entry through which an AC maintainer would be inserted to provide positive pressure. After achieving diathermy of the required site, a sclerotomy is made. This sclerotomy is made around 7 to 8 mm behind the limbus. This is the height part where the height of the choroidal mound is maximum, and we can have a safe access into the suprachoroidal space. As soon as we enter into the suprachoroidal space, blood starts to come out. And then, but a problem with this technique is that the two lips of the sclerotomy tend to fall over each other as the IOP decreases. And then we have to use additional instruments like a forceps or an iris repositor to keep these lips apart so that we can achieve sufficient drainage. So now we have largely shifted to a modified technique using 20 gauge, 23 gauge or 25 gauge cannula. So this is the same patient in which an external drainage was attempted, but in the post-operative period, we found that the drainage was not sufficient. So we repeated the procedure, but now with a modified technique. Again, an AC maintainer was put. And this time we are inserting a trocar, a 25 gauge trocar into the suprachoroidal space. Important thing to note here is that the cannula is being inserted at an acute angle to the sclera, unlike perpendicular entry, which is advocated in VR surgeries. And also the entire length of the cannula is not inserted, only the tip of the cannula is inserted. These two maneuvers ensure that you actually open the cannula in the suprachoroidal space instead of hitting the choroidal tissue and causing further damage. And you see, as we take out the trocar, the suprachoroidal blood comes out on its own. We can then apply some gentle manipulations over the eyeball so as to coerce the blood to come out of this cannula. A major advantage of using this cannula is that unlike the scleral flaps of the sclerotomy, there is a rigid tube in the suprachoroidal space, which is not going to collapse on its own, and hence a better drainage can be achieved. This is another patient, but here, instead of making the entry at 4 mm, we are making entry at about 7 mm from the limbus. And again, here you can see, as we will retract the trocar out of the cannula, the blood comes out on its own. We are able to achieve very efficient suprachoroidal drainage without much manipulation. Again, we are retracting the cannula slightly out. This opens up a new pocket and further drainage of blood is achieved. So the next question is, what is the ideal site of insertion of the trocar cannula system? As you can see in this illustration, when we are inserting the trocar at a 4 mm distance from limbus, the tip of the trocar would lie slightly closer to the choroidal tissue and hence is more likely to hit the choroidal tissue. Whereas when we are inserting it at 8 mm, this is the site where the height of the choroidal mound is maximum. So we will have greater safety. So largely we recommend that this insertion should be tried at 4 mm, at 8 mm away from the limbus, though 4 mm insertion is also very efficient. Visual outcomes are very poor. This is primarily because of leakage from ostium leading to worsening of suprachoroidal hemorrhage, snuff out of the central visual field due to IOP fluctuations, and often these surgeries have to be combined with closure of the ostium leading to uncontrolled IOP. If there is a coexisting retinal detachment or the suprachoroidal hemorrhage was involving all 360-degree quadrants, then the visual outcome is especially poor, and not more than 20% of the eyes are able to achieve visual acuity greater than 20/200. In the end, I would like to summarize by saying that we have to take all the necessary precautions for optimizing all the parameters so as to prevent suprachoroidal hemorrhage from happening. If it is recognized intraoperatively, we have to immediately close the wound, follow up the patient with serial ultrasonography to monitor liquefaction and height of CD. Ideal time of drainage would be around 7 to 14 days. And external drainage with trocar cannula system is very easy and safe to perform. Thank you.
Thank you, Dr. Saurabh. That was really a wonderful presentation on management of this devastating complication. So Saurabh, just to summarize for the viewers, so you recommend that a trocar cannula system should be used for drainage and 8 mm posterior to the limbus.
Yes, sir.
So how do you decide which quadrant you are going to operate? Is it better to do it in the, or do you do ultrasound and then make the incision in the area where there is the highest mount height on ultrasound?
So, of course, that is the most important role of ultrasonography in preoperative evaluation, that it can actually tell us what is the quadrant in which the height of the CD mount is maximum. So we find out the quadrant in which the mount is at its maximum height, and then try to drain from that quadrant only.
Okay. And you mentioned 3 gauges. So what gauge would you recommend?
So the wider the gauge, easier would be the drainage of the blood. So 23 gauge would be a good compromise, because 20 gauge is probably too large, and 25 gauge would require too much manipulation. I have been using 25 gauge because in our system, 23 gauge trocar cannula is not available.
So is there any risk? Have you had a case where you had a wrong entry and it has perforated some other structure, the cannula, trocar cannula system?
No, sir. So we have to take necessary precautions that the trocar should be inserted only to a partial length. So the length of the cannula is about 4 mm. And if you talk about scleral thickness, about 8 mm away from the limbus, it is somewhere close to 0.6 mm or 0.7 mm. So even if 1/3 of the cannula is inside the sclera, that would be sufficient. And we take care that the trocar is directed posteriorly, so that it lies away from the choroidal mount as much as possible.
Thank you, Dr. Saurabh.
Thank you.
So he's always available to salvage our devastating complications. So do we have Dr. Mimi or Dr. Pandav?
Tanush, Mimi says she's waiting to be admitted. Can
Okay.
back end team check?
So we can have some questions. So Tony, the question for you now, there is a lot of confusion. Yes.
I'm not sure what Mimi, can you ask your team to admit her? She's waiting to be admitted.
Yeah. I'll just message them. So
Okay.
Tony, just help us decide. Like, there are a lot of people starting glaucoma surgery, and there are essentially the issue of glaucoma drainage device. So which device to choose from? Because you have the Amer glaucoma valve, you have the barbell type and the RD implant, then you have the Paul glaucoma implant, and now you have the Amer clear path. So what is the decision making on which implant to choose and carry on in your career forward? So that is a big question for a lot of youngsters. So please elaborate on that.
Yes, that's a great question, Tanuj. A lot of people ask me which one to use, because now we have a lot of options. Now, if the glaucoma is quite advanced, and the most important thing is to achieve the lowest possible pressure, I would choose a device that has the largest plate size and a non-valve. That should be either the Marvell, the Paul, sometimes the Multino 3, although it's a little bit smaller, the plate size around 250. Now, if immediate IOP reduction is important and there's some risk for complications with hypotony, then I would choose a valve implant. So the only problem with the valve implant, the valve devices, sometimes the long-term IOP is a little bit higher than what you would want, to achieve. Other issues that you would want to look at, if the pressure is a little bit more, if you could with non-valve implants, there are other ways to achieve lower IOP in the immediate postoperative period. You could use venting slits to decrease the IOP. It works quite well, but sometimes it could be unpredictable, but it's a good way. With the Paul implant, you have a smaller lumen size. It decreases the risk of hypotony in these cases. But even with the traditional non-valve devices, you could use an intraluminal stent, as mentioned by Dr. Astrayanda. I prefer either a 4.0 or a 5.0. Then just do a ripcord, allow it to be removed later on via a ripcord technique. Thank you for the question.
Dr. Manavdeep, would you like to ask any question to any of the speakers?
In fact, I would ask once again, Dr. Sushma, Can she tell us all the possible ways of blood repair? Whatever she has told. In addition to that, is there any other procedure that she knows of that is practiced? If she's there.
Thanks, Dr. Manadeep. The lab repair procedures, what I have been largely doing is what I did not show there is one another way is pedicle graft, which actually Dr. Anthony showed for covering the tube. So that is something that I have used. So there are you can use a pedicle graft or a free flap or, advancement with the various VY-plasty. I think our speakers are there. So maybe we should proceed.
Dr. Manadeep, you can invite Dr. Pandav now.
Yeah, yes, sir. Yes, Dr. Tanuj, it's my privilege actually to invite and introduce Dr. S.S. Pandav, who is the immediate past president of Glaucoma Society of India, and he currently heads the Advanced Eye Center of Postgraduate Institute of Medical Education and Research at Chandigarh. And he's again a voracious and very versatile researcher and a wonderful surgeon. So over to you, sir, Dr. Pandav, sir.
Thank you, Manavdeep. And I got connected just in time, actually. I have been struggling with the connection, but luckily I'm online now. So I'm going to share my screen. Okay. Can you see my screen?
Yes, sir.
Okay. So thank you, Tanuj, and thank you, APGS and AIOS for including me into the program. So I'll be talking about the hypertonic maculopathy. Nothing to declare. So hypertonic maculopathy after trabeculectomy is actually quite common. But the problem happens when it persists. So persistent hypertony, which is kind of defined as IOP less than 6 millimeters of mercury and lasting for 12 weeks. So transient hypertony is very common and usually is not a big issue. It recovers, but once it becomes chronic or persistent, then there could be a problem with and can lead to a decrease in visual function. There are many reasons for persistent hypertony, blood leaks, overfiltration, cyclodialysis, and many others actually. But in this talk, we are basically talking about the overfiltration following cataract surgery, which actually is the one which is difficult to manage. And the maculopathy happens when there's a long-standing hypertony, and the loss of central vision, clinically it presents like a loss of central vision and some distortions. And you'll see the choroidal and retinal folds. There would be dyschedema, the vascular tortuosity, and there may be a subtle macular edema, which can be missed clinically, but if you do the OCT, you'll find that there may be a macular edema in many of these cases. The decreased vision is due to macular changes, which are generally temporary because of the kind of a change in the orientation of photoreceptors and some degree of edema in that area. But if the condition is not resolved early, then these changes may become permanent, and there could be a permanent decrease in visual acuity. And of course, hypertony can lead to cataract formation and some other complication, which could be the cause of decrease in vision. The risk factors for hypertony are young age, male gender, myopia, use of mitomycin C, that's I think very important here. And also, if the ciliary body is already compromised and if you do splitting surgery, sometimes it could lead to excessive lowering of intraocular pressure. So typically a male myopic patient where you have used a young male myopic patient with the mitomycin C, that's a kind of typical setting for hypertony to happen. And one of these studies by Penin and others, they found that diabetes and choroidal detachment actually kind of protective, in the sense that if you have diabetes and if there's a choroidal detachment, somehow it doesn't happen. So as I said, the hypertony is quite common, but if you look at the hypertonic maculopathy, the incidence reported varies greatly from 1.3% to almost 20%. And it has also been seen that the primary surgery has a higher risk of hypertony than the repeat or combined procedures. And also the sclera, the reverse of to reverse the hypertony, it's possible to reverse the hypertony. And once you have reversed it, the visual recovery is quite good. And say up to 90% of the cases, they will have a good recovery. But again, there's just some percentage of cases where recovery will not be complete. So managing reversal for hypertony is, and the maculopathy is important. And the patients without maculopathy, and if there's no decrease in visual acuity, then these patients can safely be observed. Because hypertony, basically, there's a statistical hypertony, and also you have what is a clinically significant hypertony. So what I said, IOP of less than 6 millimeters of mercury, basically we are talking of the statistical hypertony. But sometimes patients may not have any visual symptoms even at 6 millimeters of mercury pressure. So there, the maculopathy doesn't happen. So you have to look at the patient from that angle as well, because sometimes maculopathy may occur at 6.5 or 7 millimeters of mercury IOP as well. So I think that would be considered as a hypertony, clinically significant hypertony in those situations. Reversal of hypertony is important, and this is also quite challenging. Many procedure techniques have been described in literature, which varies from cryotherapy of the bleb to laser application to the area, injection of autologous blood, compression sutures, resuturing the scleral flap, and some more. So this is a case of 38-year-old male, which we have done bilateral juvenile open-angle glaucoma. And the right eye had already undergone surgery with 8 millimeters of mercury pressure. The left eye is 30 millimeters of mercury pressure, and this is the fundus picture of the left eye, and visual acuity is 612 in both eyes. So he underwent trabeculectomy in the left eye with mitomycin C, and in the post-operative period, the IOP was low on day 1, day 1 week, 2 weeks, some increase in IOP, but subsequently it went back again to 2 to 3. So even at 3 months, the pressure was just 2 millimeters of mercury, and there was a decrease in visual acuity as vision had gone down to 360 by this time. So and you can see the bleb is actually very diffuse here. This picture has been taken the OR before the repair of this. So it looks a little congested, but it was like a avascular, a large infiltrating bleb, and you can see there's the macular folds are there, and OCT actually has some fluid also in the macular area, and that may be the reason for decrease in vision. So what we did in the case was that we used a combined technique for compression suture and the scleral dissection and fixing. So what we did, we went behind the bleb and dissected the conjunctiva and the tenon capsule and identified the scleral flap there, which we thought was overfiltering on this area as well as on the other side, but more in this area. So that's the previously applied suture at the apex, and we put another suture at a place where the scleral, the partial thickness scleral flap was actually open, and then we close this small incision. So this is done through a small incision, and because the other side we don't want to suture it because it could have led to high pressure, so we played a little safe in the sense that we put a compression suture on the other side, so that if the pressure goes up, we have an option of removing this compression suture. And also compression sutures with time, they become a little loose, and the IOP may drop again. So basically, in this patient, we used a double technique of suturing the scleral flap directly as well as a compression suture. And subsequently, as you can see, the pressure, this was about 8 months after the repair procedure. And we can see the pressure is staying very well around 10 millimeters of mercury, but the vision actually didn't improve to the baseline. And we are at a 618, and you can see there's some changes in the macular area there. And in the fundus picture also, we can see those striae, the pigmentary changes are still visible. So probably because of these pigmentary changes that happen, the retinal pigment epithelium. So the visual acuity is down, and also there may be some evidence of some membrane formation there. So that might be the reason that his visual acuity still remains low. But I think that grossly there's a reversal of the hypotony as well as the fundus changes that were there earlier seen in this patient. This is another patient where we had a we could see the skirt edge was actually over-filtering on this side. So here we use a direct transconjunctival suture in the skirt flap. Now this has been described by Letatre and others, and in their data, in a small, small number of cases actually, they said this about more than 90% cases they succeed. Now this suturing was done transconjunctivally. With time, this will get internalized and it will not be visible on the surface. So this again a very good technique to deal with hypertony. The resuturing of skirt flap after opening the conjunctiva posteriorly has been shown to be effective to the tune of 89 to 90%. And that's been published, I think, many years ago. And also the compression sutures, the success rate again, there are many studies on kind of data is available on this, and 60 to 70% success rate is kind of what is reported in literature. So what we did was we used a combination of these procedures. We combined skirt flap suturing and compression suture reversal, and that reversed the hypertonic maculopathy in our patient, and also improved the vision, though it was not a complete recovery, but we did get some improvement. This is another patient with IOP is less than 6 millimeters of mercury for more than 12 weeks. This is again a young patient, young male myopic patient with TRAP with MMC. Actually, he underwent surgery in both eyes. The right eye was done first, which gave us a good IOP of 13 millimeters of mercury. And you can see that there's a good bleb, which is a bit localized as well, but I think is filtering nicely. However, the left eye didn't behave in the same manner. You can see a very diffuse bleb there, and the pressure is less than 6 millimeters of mercury in most of the follow visits. So here we use a little different technique. What we did was that we delimited this bleb. So this is the bleb. So what we did was we made a conjunctival incision here vertically, the linear incision, radial incision actually, to the one side of the bleb. And we put interrupted A0 Vical sutures. And these sutures, when we took these sutures, we included the conjunctiva tendon as well as a little bit of bite of the episcleral tissue, so that it was stuck to the sclera, so that there was kind of barrier was created. And you can see this is about 3 weeks post-operatively. And you can see actually not only in this area, the bleb is getting like a delimited, but also you can see there's even in the area which has not been dealt with, there is some vascularization is happening in that area as well. And this is how it was seen, 15 weeks down the line. So the area, this is where the delimitation was done, but I think even the rest of the bleb is actually walled off. So I think once the fibrosis is stimulated in this area, I think the fibrosis also occurs in other areas as well. So I think this is another technique which can be used to deal with these cases, because there is no one way to deal with these patients. So to summarize, hypertony is common after glaucoma-filtering surgery. Persistent hypertony can lead to decrease in vision. Reversal of hypertony is difficult, but can be achieved in most of the cases. A number of procedures have been described, and the procedure we choose actually depends on what is the underlying cause. If there's underlying cause for hypertony, that has to be dealt with as a leakage, or the bleb needs to be excised, or so that can be done. But in the absence of that, again, different procedures have been prescribed. We didn't have a good experience with the injection of the autologous blood, so we don't prefer that. But I think direct closure of the scleral flap and also in a compression suture, they work better in my hands at least. So the careful planning is actually required so that intervention can be planned. And once the hypertony is reversed, there is a usual improvement in vision unless it's delayed too much. In that case, what literature suggests is that maybe about 20% cases may not actually get back to the baseline vision where we started. Thank you very much once again for the opportunity. And thank you all.
Thank you, sir. Two brief questions. First is, why hypertonic maculopathy is more common in juvenile open-angle glaucomas than adult glaucomas?
I think Yeah, yes.
Okay, you please reply this, then I'll ask the second question.
Juvenile, like we are dealing with the young people, and the young males are usually more prone, and if they're myopic, even more prone. So probably it has to do something with the rigidity of the sclera, because the sclera is kind of elastic in these. And whenever there's a lowering of the IOP, so because the elastic sclera, there would be a little, the kind of inward pressure because the elasticity, and that will create a little redundancy in the sclera and the choroid and the retina. And because of that, a relative redundancy in the choroid and retina, it will be thrown into the folds in the posterior pole area. And that's what, typically causes it. But if the sclera is rigid, if it's a, elderly patient, and if the sclera is thick, and there probably, that redundancy is not as much, or doesn't happen, and probably we don't. So that's just one of the hypotheses that we have, but there may be other mechanisms. They are.
So the second question is regarding the compression sutures. One is it becomes loose over a period of time, and then the bigger problem is that it's extremely difficult to apply this because there's bogginess in the conjunctiva because of the large bleb, diffuse bleb, and it is not easy to reach the sclera. Unless you take the sclera into the white, it is not going to be effective. So taking the sclera is very, very challenging. So I just thought during this session itself, it just came to my mind, what about giving a conjunctival incision beyond the bleb and then going through the sclera under direct visibility while applying this, and then over that stitching the conjunctiva. So what about that? Can we do that?
I think that's what we did in the last case, which I showed you, where I made it.
No, sir, that was a radial incisions you were saying. I'm talking of the compression suture. For applying the compression suture using a small incision just to pass the suture at the sclera.
Exactly. I think you're right in that sense, because sometimes it's difficult when there's too much of fluid in that area. How we do it, basically, you just compress that area so that displays the fluid, and before you pass the needle. So press with something like you do for laser suture lysis. So here you, with any instrument, you just press it for some time and displays the fluid. So then it becomes a little easier to identify and pass the suture. And but you are right, with time they do become little loose, and they also get internalized. The second thought that maybe you can make an incision and then pass it through the sclera, but then we are actually opening up the conjunctiva, the tendon space there. If we are opening up that tissue, then better option would be, just to fix the scleral flap if it is loose there. But if scleral flap is not identifiable, not loose, then maybe you could try this procedure also. But,
so if we do suturing of the scleral flap, then many times it leads to failure of the bleb.
Lead to tear of the bleb.
Failure of the bleb.
Yeah.
Failure. And the IOP starts rising beyond what we require.
Yeah, that's true. That may happen sometime. I think that was the reason actually I combined, in the first case, I combined the two procedures. On the one side, I actually closed the flap, but on the other side, I used the compression suture. The reason was that only so that we don't get into interactively high IOP in the post-surgical period. So that was actually the idea behind combining these two procedures.
Right, sir. Thank you, sir. Dr. Tanuj, you please take over.
Dr. SK, you want to invite Dr. Mimi, please?
Thank you.
SK, you are muted. Yeah.
Yeah, sorry. Thank you, Manavdit and Tanuj. Yeah, I would like now to introduce our last speaker, Dr. Mimi Wati Zahari. She's a professor at the Department of Ophthalmology, University of Malaya, here in Kuala Lumpur, Malaysia. And she did her glaucoma fellowship at the Royal Victorian Eye and Ear in Melbourne. She's also a board member of the APGS, and she's an avid marathon runner and also an iron woman. She runs, she cycles, and she swims. Today, she is talking to us on malignant glaucoma. Over to you, Mimi.
Thank you for the invitation. I shall share my screen. Do you hear the?
Yeah.
This is actually an audio. Wait, let me see. Why is it not running? Oh, sorry. Do you hear the audio as well? No?
No.
Okay. I think I have to voice it out. Okay. So this was supposed to be pre-taped, but never mind. Good evening, everyone. So my topic is on malignant glaucoma. And this was initially described by Dr. von Graffi way back more than 200 years ago. And it is characterized by high IOP, a shallow flat anterior chamber, and the presence of a patent peripheral iridectomy. Now, the word malignant is used. It's not as if it's wrongly used, because malignant actually means death or deterioration. But in this case, the glaucoma is a sustained type of glaucoma, easily worsens, very difficult to treat, and can progress to blindness. So it is quite apt that we probably stick to the term malignant glaucoma. Fortunately, it is quite rare. Usually happens in angle closure glaucoma cases, about 2 to 4% of those undergoing trabeculectomy. And it is less frequent in those cases of POAG, undergoing trabeculectomy. Women are more likely to have this condition more than men, and it's said that it's because, we have shallower anterior chambers, and thus this predisposes us to the aqueous misdirection. Now, this malignant glaucoma can happen anytime, it's either intraoperatively or anytime, even months or years after surgery, and it can also be recurrent, especially if you don't treat it well, or you don't do the definitive treatment. Now, there's many different definitions, and aqueous misdirection syndrome is the commonest that you hear. It is also called capsular block, ciliovitreal block, ciliary block, subcapsular fluid entrapment, positive vitreous pressure, intraoperative fluid misdirection, infusion misdirection syndrome. So these last three definitions are usually used when it occurs intraoperatively. So there are some authors who actually decided that should make the definition as fluid misdirection syndrome, and acute is supposed to refer to those malignant glaucoma which happens intraoperatively, and chronic are for those cases which occur like the natural malignant glaucoma nature. Now, the mechanism, there are several mechanisms, but basically the end result is shallowing of the anterior chamber. And this is due to forward movements of the lens and also anterior rotation of the ciliary body forwards. And this actually will cause sometimes the ciliary body would actually touch with the lens if it is phakic, and with the vitreous if it is in aphakic cases, and the aqueous is misdirected posteriorly into the vitreous, and thus there is positive pressure which climbs up behind the vitreous and pushes the lens forwards. So this is like a very vicious cycle. So in the end, the anterior chamber gets shallower and shallower, and in the end you get a really flat AC. Now, Dr. Quigley has also postulated that it's not only an anterior segment problem, actually posterior segment, you find that there is also choroidal effusion, which causes this increase in vitreous pressure. And there's something about cases with malignant glaucoma is that the vitreous is a bit more thicker, than usual. So that's why they feel that the aqueous cannot actually penetrate the vitreous that easily. Okay, so the common risk factors include shallowing of anterior chamber after surgery. It also often occurs in eyes which are small. So history of angle closure, those with hyperopia, also occurs with those with pseudoexfoliation, because these are the cases where the lens is, the zonules are lax and the lens can move forward easily, and can also occur in cases where there is a lot of intraoperative stress, like patients who are uncooperative during surgery because they do the Valsalva maneuver. Diagnosis mainly clinical. It should look like a acute attack of angle closure glaucoma, and that is when you need a high index of suspicion to know that it is not your typical AACG, because you still have high IOP, flat AC. However, there is no iris Bombay. The AC is flat both centrally and peripherally, and there is usually, a presence of a patent PI which will negate your acute attack of angle closure. And also there is no posterior segment abnormality. So there's no suprachoroidal hemorrhage or any choroidal detachment causing the shallowing of AC. And you find that these cases worsens with pilocarpine or other conventional treatment. And if, let's say, you have just perform a surgery and you still have the paracentesis, you will find that it is very difficult for you to reform the anterior chamber with a viscoelastic. Now you need a very high index of suspicion to know that if it is malignant glaucoma, is the case, is it a previously operated case? Has the case got a previous angle closure attack? And if the case actually has a gradual myopic shift post-operatively, and if there is overfiltration following glaucoma surgery, has there been recent laser suturelysis or bleb needling? Was cycloplegics recently stopped, and this can trigger the attack? Or oppositely, was myotics recently started? And if there is a previous malignant glaucoma attack in the other eye, the diagnosis is by UBM, where you actually see the shallowing of the anterior chamber and the iris corneal touch, the lenticular iris touch. And you can also see the ciliary body, which is usually rotated anteriorly. In some cases, you can also see ciliary body effusion. And this shows the anterior rotation of the ciliary body towards the iris. And that is why the aqueous is misdirected posteriorly. Now, differential diagnosis, UBM can help you to differentiate between pupil block glaucoma, because in pupil block, you will find that there is your iris bombay, and there is actually some aqueous posterior to the iris, which is not present usually in malignant glaucoma. And in plateau iris, you see a flat iris, and you also see an anterior rotation though of the ciliary body, but the iris is flat and the anterior chamber is very deep in plateau iris. Now, management, as usual, you go through the medical therapy. If it doesn't work, laser therapy and surgical therapy. So basically what you want to do for medical therapy is you want to dilate to the pupil, you want to relax the zonule so that the lens goes backwards. You need aquosuppressants, osmotic agents, especially agents which of course shrinks your vitreous. So for example, your oral glycerol, your mannitol would work very well. Now, if this doesn't work, then it depends whether the patient is phakic or pseudophakic. But the basic thing is that you want to make a hole, you want to disrupt the anterior hyaloid phase. And you have to figure a way how to get to this. So it's easy if you're pseudophakic, but it's not as easy if you're phakic. So if you're a phakic patient, usually they end up having, having to have cataract surgery. Now, for laser therapy, as mentioned just now, you need to rupture the anterior hyaloid to release the trapped aqueous from within. So you can do the YAG laser through a PI, need to be a large PI, or through the pupil. Or some people have mentioned they can do the laser through the IOL, intraocular lens positioning holes. This is, of course, for pseudophakic patients. It has been mentioned that argon laser photocoagulation can be done to shrink ciliary processes, but as you know, it's not easily seen, and you need a very large PI to be able to see your ciliary processes through the PI. So transscleral cyclodiode laser is usually helpful, and this case series actually advocates application of 20 to 30 pulses over 2 quadrants, and it is found it is sufficient to break the cycle of the misdirection and actually prevents future recurrences. Now, surgical management is, of course, with pars plana vitrectomy, where you actually, remove the vitreous and remove the hyaloid phase. So it's sort of you make the anatomy go back to normal. The aqueous would not flow posteriorly. However, some authors have advocated that this is not enough, that you actually need to do a total vitrectomy and you need to do a tunnel where the tunnel is created so that there is actually a tunnel connecting your anterior chamber through your iris and through your zonules, all right? And you need to do a total vitrectomy and shave off the vitreous, anterior vitreous, so that the vitreous does not block this pathway, and only then you won't get recurrences from malignant glaucoma. This is to share with you just a case which was published by some of my colleagues a few years ago. A 56-year-old female, known primary angle closure glaucoma, still phakic, with a peripheral iridectomy on topical medication. A year later, she presented with symptoms suggestive of malignant glaucoma. There was shallowing of the anterior chamber. And as you can see from this photo, the shallowing is actually quite diffuse. Yeah, it's not, you don't have the iris, typical iris bombe, and it's really, really shallow. And this shows that the PI, which was done, is actually patent. So this sort of is highly suggestive of a malignant glaucoma with a shallow AC, high IOP in the presence of a patent peripheral iridectomy. So this was the UBM which was done, which was very shallow AC. You can see the anterior rotation of the ciliary body. So what was done for these patients after she was medically stabilized, they did a phacoemulsification with the intraocular lens implant to remove a nuclear sclerotic cataract, and of course together with the PPV. And you can see post-operatively the UBM shows a very deep AC. And this is the appearance post-operatively. Nice clear cornea, deep AC with a pseudophakia. Now, this is another case shared by another colleague, Dr. Pusparaman, a 75-year-old lady. She underwent uneventful phacoemulsification, not even known glaucoma. However, she is a hyperope, has a short axial length. And when she came for routine post-op examination, she was noted to have progressively increasing IOP. It was 18, then 22, and then it was like 25, 28. And at the same time, they found that there's a gradual shallowing of the anterior chamber. So because of that, she was actually started on atropine for 2 weeks and monitored every few days. But the IOP kept climbing up and the anterior chamber did deepen for a while, but again, still started shallowing again. And until the highest IOP reached was 40 millimeter mercury. So this patient straight away was posted to undergo phaco PPV. Sorry, just a PPV because this one is already pseudophakic. And you can see after phaco that the anterior chamber is nice and deep. So in conclusion, malignant glaucoma remains one of the most difficult problems to diagnose and manage in glaucoma surgery. A high index of clinical suspicion is important. Imaging with UBM is essential to support the diagnosis. Surgical management is important to reverse the main pathologic mechanism, and this is to avoid recurrence. Because if you just treat the patient medically, you may have to put the patient on atropine for at least a year, if not a lifetime. Thank you very much. How do I unshare? Okay.
So the top of the screen, your.
Okay. My screen. Stop video.
Stop share. Stop share.
Okay. Stop share. Okay.
Yeah.
All right.
Thank you.
Okay. Sorry.
Thank you, Mimi, for an excellent overview.
Thank you.
How long normally do you try medical therapy before you go for surgical?
I think it depends on the cases. So like the cases that as mentioned, if you see that atropine does not work, and it depends. If let's say the patient is phakic, you know that the lens has to come out. So then you tend to go in quite quickly. But if the patient is pseudophakic and sometimes atropine does work and sometimes it doesn't. But I find that sometimes atropine, after you stop it, it can recur. So in the end, we do send the patient off for PPV. But if the patient has got very high IOP and, with corneal edema and because these cases are usually glaucoma cases, and if let's say the optic nerve is already compromised, then I guess you need to go in rather quickly.
Yeah, one last question. If you have malignant glaucoma during cataract surgery, maybe towards the end before inserting the lens, what would you do? Will you stick a needle do a Chandler's procedure, or you call your ER colleague?
No, actually, I just had a very eventful experience. I think just last week or 2 weeks ago, I was doing a Barbell implant in a case with a failed trabec by someone else. So what happened was, he's about 40 over years old. I think he's just a mild myope. Because when I do my Barbell surgery, I always do a scleral flap and I also put the graft. So I do both. I do double. So after I did the scleral flap and entering the AC, suddenly the AC just flattened, just typical, totally flat. And the worst part, the cornea also became very opaque. You know, so I was actually thinking, oh gosh, did I inject some gentamicin or something which I'm not supposed to, you know, that the cornea became opaque, or is it because of the IOP? And the cornea, the eyeball came rather hard, but not so hard like a suprachoroidal hemorrhage kind of thing. So what I did was, and I actually assume it was probably malignant glaucoma, I may have flushed some fluid behind through the zonules to the back. So what I did was with the blue needle. So it's something like a Chandra's procedure with the blue needle, which I used to make the port for the Barbell tube, actually went behind the iris. And then I saw a bit of vitreous coming out. Of course, I asked the anesthetist to give mannitol. And then I was actually thinking, I've already placed my Barbell. I was thinking that I would need to do a second procedure, close up and put in the tube later because I can't see anything. But amazingly, and with a lot of prayers, I think about 15 minutes later, the cornea actually cleared enough for me, and AC deepened enough for me to put in the tube. Yeah, so I think IV mannitol is a must and it's a lifesaver, and a lot of prayers. I don't know if anyone else has the same experience, but it was really traumatic for me.
Yeah, I think time is already running out. I would like to thank all the speakers for their excellent presentation. And again, I would like to thank the All India Ophthalmic Society and the Indian Glaucoma Society, Professor Tanuj, Professor Manavdit, and all the speakers in the usual manner. And I would like to invite you to join us in the next APGC, which will be in Manila in May 2024. And also invite all of you to join as members of the Asia Pacific Glaucoma Society. Thank you, everyone. Have a nice evening.
Thank you so much.
Thank you, sir. Thank you so much.
Thank you for the invitation.
And good evening. Good night.
Thank you.
Good night, everyone.
Bye-bye. Thank you.
Bye-bye.